you're saying to click on the link. But I'll stay over there and also keep a lookout. But the participants should know to come over to this side.
Okay, yeah.
It's obvious. Thanks.
All right. Okay, guys, let's do this. It's time.
All righty. Is everybody in the room then? Awesome. We got a full house now.
I think there's 10 people in the waiting room.
I don't know how to admit anybody.
Andrea, you're letting them in?
Yeah, I can let him in.
Okay, perfect.
And
10 people waiting room. Boy, that's something I've never heard of.
Yeah, and if I see some stragglers, I'll try and keep an eye out and let them in, okay?
Alrighty.
Perfect, thank you. All right.
Alrighty, is everybody excited? Pre-conference workshop, SAEM day 1. This is great. Alrighty. Hello, everybody. Yes, everybody, welcome. Welcome to the session. My name's Philip Michela. I'm here with a group of collaborators that we've worked on for a couple of years now with this. In case you think you're not in the right room, you're here for a take and bake, low-cost models as taught by the pros. So this is a Sim Academy sponsored workshop where we're gonna walk through some DIY make-at-home models that we use in our own shops to try to teach some critical procedures, and maybe not so critical, but could be critical for the patient. Procedures that you can take home and use your institution, and then also engage you in a way that hasn't really been done before in a workshop. We want to engage you as possible collaborators as we grow as a specialty, trying to grow simulation both as a specialty within a specialty and try to make our models better and to get some academic or shared, academic productivity out of this. So this is something that we haven't ever done before, and we're really excited. And so this is going to be a give and take. We're going to give a lot and we're going to take from you, and then you're going to take these back with you and build them at your own session. So, all right, if we can go to the next slide. The folks that are in here to help with any kind of questions or anything is Andrea Ray. We also have some medical student ambassadors. They will wave. There's Maurice and Kelsey right there. So if you need to, please put any questions or comments and stuff like that in the chat box. We will be kind of going through the chat box. We won't forget about you and to try to get to everybody. We'll also have some predetermined breaks in between so that you're not stuck looking at the screen for 3.5 hours. This should be a lot of fun. All right, so this is everybody that's going to be talking today. This is myself, and my name is Philip Michela. I'm with Prisma Health. We're down here in South Carolina. One of my good friends here is Dr. Roth, who actually runs our simulation through our emergency department. Steph Stapleton from Boston is going to be here, and she's also very active on the Sim Academy. She's published in multiple papers, Charles Lay as well, Vanderbilt, Mike Cassara, Nuran Nadir, and Ian Julie. And they're all really wonderful people that I've worked with for many, many years. And these folks are on the forefront, as it were, of making new simulation procedural models. So you really are being taught by the pros. We don't have any disclosures. And basically the whole objective of this is to describe a variety of options for creating low cost and low fidelity sims with everyday craft materials. This is stuff that you can buy, you can order, you can have shipped to your house, whether it's Amazon or whatever other system you may otherwise use. We're going to demonstrate actually how, step by step, to create several of the models that we're going to discuss. Some of the other models that we'll talk about have step-by-step instructions that are buried in here, and so we'll be able to share this after, and these are things that you can easily make at home. And then we're going to try to identify some venues for how to convert these DIY models and these new innovations into peer-reviewed publication and presentation. Because it's one thing to create these models that you think work, it's another thing to be able to spread that knowledge, improve on the models, and actually publish on this and make it something that is a worthwhile academic achievement, both for yourself, for the department, and to really prove that these models do what they say they're going to do. All right, to really get our learners to that next level where they are proficient at these procedures. Okay. Basically, we're going to have some introductions and background about us and our different models. Then we're going to go into the actual model presentations with some slideshows. Then we're going to break up and have each one of our presenters, actually walk through how to make a model, right? And Part of this is to sort of break down some of the barriers. Some of the initial barriers in trying to do this as a DIY is just working with the materials. And so going step by step, we're going to show you how do you work with these materials, so that way you get some confidence that when you want to take these models and build them back home, that you're going to be able to hit the ground running. Okay. Then we're going to talk about the scholarship and research associated with some of these models. And this is where we're going to try to really engage you, right? And we're going to try to work back and forth and talk about how do we build an academic product, something academic out of this DIY model, right? And how we as a group, and I mean we as a group, everybody that's here, to try to build something that we can try to get published. And then we're going to talk about the next step with that is not only trying to get it published, but really showing that these models have validity, that they work, okay? You'd be surprised at how many of the actual models that we use every day that are commercially sold that actually have very little validity evidence behind them, right? And we want to sort of change that as simulation becomes a more and more robust specialty within our specialty. We want to show that these things have validity and they do what they say they're going to do, so that we can improve on them later. That's the other part about this. Sorry, Nick. So who we are and who you are, we all think we're a little bit of House and a little bit of MacGyver. I'd like to think I'm a lot more MacGyver. My wife would wish me to be a lot more MacGyver, at least looking. So anyway, why you're here? You're here because you want to get some new tools for education. You're here likely because you said, hey, they're going to teach me how to make some models that I can take back to my own shop and use. And that is true. But we want to go a little deeper into that. We want to talk about what are the models that you're currently what are the models that you're currently using, and how did you find those new sim models, right? And how you're implementing those models into the sessions. Because it's one thing just to have a model that may or may not actually get your person to a level of proficiency, but it's another to actually show how you're supposed to implement these into full-length sessions, right, with debriefs and validity and measurement and all these different things to make sure that you have clear goals to set off for your educational advancement, to say, I want to teach somebody this is how I'm going to evaluate it, this is how I'm going to prove that this person learned it, and how do you measure that person that then came proficient, right? What are the critical actions in the procedure? What do I have to make sure that my learner gets to be proficient in, right? So I'll open it up to the group a little bit. How do you find new sim models? If you are in your department and you're anywhere, where do you go? Anybody have any comments? Please speak up. Not all at once, huh? All righty. Well, I bet most of you are actually just kind of scouring the internet and you've gone to any kind of number of sites like Bard or some of the other sites or Mannequin or SimMan and stuff like that. And you've basically just gone on to commercial sites because you think everybody's using them, right? So if we go to the next slide here, it's basically commercial versus homemade, right? Well, when we talk about it, it's like, which is better, right? And so when we talk about it, just because a website has a sim man that can do everything but walk and talk, right, doesn't mean that it's actually going to be useful for all the different procedures that you want your learners to learn how to do to then be proficient in the real world, right? Because right now we're not at that point where a sim man can do everything, right? So this is why some of us have come up with homemade models and DIY models, because we recognize that these sim man models and some of the commercial models don't give us a real tangible procedurally based model, okay, to teach critical procedures or various procedures, right? And so what we're trying to say is that it doesn't always have to be on a website. It doesn't always have to be shiny and new. These homemade models that we use are ones that we use in our shop that are useful, that can be useful for your learners, right? So that's the other part about it, is how do you define better? Does it have to be shiny and new? Does it have to be something that costs a lot of money? No, right? It has to be something that has clear educational goals, set forth a part of the procedure or the entire procedure or the critical actions of that procedure that are necessary for your learner to become proficient, right? Basically, multiple simulation programs can be totally underfunded. There is not a lot of money that is out there to pay for everybody to have multiple sim mans or all the biggest whiz bang things, right? No place has an unlimited budget, especially coming out of COVID, where everybody is strapped for cash across the board, all their hospitals. You have to be budget conscious, right? And there are basically special occasions and different things when you buy some of these models that are very expensive, right? That if they're otherwise misused or anything happen and your warranty expires, there is no support for you, right? And so part of the reason by having some of these DI models means that you're able to troubleshoot it, remake them, and actually make it to the next level with your learners and improve on them in a real-time way. There's limits on learners and numbers of attempts, right? Especially if you've had cadaver lab, there's only so many times that you can cut on a cadaver's neck where somebody's gonna go right through the same cut that you made because they can see it, right? And so that's the other part about it with some of these other commercial models is technically they're not really made to be reused and reused and reused, right? Some of them are made that they're used several times, but then you can see the track, you can see the hole. How many times have you gone onto a sim man to try to do a chest tube, and that cover right there has been cut into multiple times that you can see exactly where to go, right? Are you really showing your learner how to do the procedure right if they can just look and see the hole that was always already there and just go through the same hole? No, right? That's why some of these DIY models for us are really useful. Even if they're low fidelity, they still get to the critical actions and what are the parts of those critical actions for that procedure to be successful. So the next one, please. So what we're trying to get for is basically training for mastery, right? So this is based on our current ACGME competency-based medical framework, right? And so what we're trying to get through, and this has been pioneered by multiple sites, you know, places like Chicago, places like everybody have tried to show how to get to somebody to be a master, right? And so what we're trying to get through is that you need baseline information, training with some sort of tool or with mastery, right? Then you have some post-testing on the simulation with an evaluation tool that then you actually see whether or not they're actually able to perform the procedure with whatever evaluation tool you're using, make sure that they pass, and then you have follow-up and retesting, right? Because it's one thing to do it one time, it's one thing to have a critical session, it's another thing to make sure that that is retained and that that person is obtaining a level of mastery, especially with certain procedures which are not high volume, things that you're not doing every day, right? If I was gonna ask an EM resident to read an EKG, they're gonna obtain a level of mastery very early in that because they see an EKG multiple times a shift, right? But if I'm asking them how to be a proficient at things like lateral canthotomy, well, that's different, right? There are some of my ophthalmologists that I work with that have never done a lateral canthotomy, right? So, or recessive hysterotomy, right? For our OB colleagues. And so this is why some of the simulation is necessary and parts of simulation are necessary, meaning that you have to have a model that has some sort of validity, some sort of efficacy to that that person can do the critical actions that are necessary for that procedure to be successful, okay? Next. All right, so this is where some of our DIY models come in again, right? We're talking about common crafts. The goal is to have low-ish fidelity. What I mean by that is that, yes, it may be a cardboard box and it may be some skin draped over a cardboard box, but the feel may be what the same, okay? It may be that this looks like what this is gonna look like, or that when we do some of these models with the eye, that you get the same consistency of what the cornea will feel like and be able to use the tool to get the burr or to get the foreign object out, right? So when we say low-ish, not everything has to exactly look and act and feel like the human body, right? We're not there yet, right? What we're trying to talk about here is that we're using different models and different materials to make sure that we get the correct aspect of that procedure that is necessary to be successful. It's the feel. It's how does it look under ultrasound? It's how does it look when you look under the slit lamp? It's how does it look like when it looks like when you go under fluoroscopy, right? Or how do you make sure that you go through the correct steps for a recessive hysterotomy, right? It may not feel exactly the same, but it makes sure that you go through the right steps. And the goal is to familiarize yourself with the procedure and the procedure steps, the equipment that's necessary to be successful, and again, certain aspects of the procedure which are critical, whether it's the feel, how it looks under ultrasound, what are those critical aspects that you can then get your learner to be proficient, right? So basically when we talk about it, why do you want to build a model, right? That you want to build a model because you want to have deliberate practice to make sure that your learners get to a level of mastery, right? You want to make sure that they can do that procedure successfully, right? As part of that, you want to then be able to assess them. You want to be able to make it formative plus summative, and then have some combination both of the model, the session, and the evaluation tool, and all of these come together in a concert to make sure that you have something that is a valuable educational tool to take someone that's from a learner to somebody that is a master, and the ability to check them off again in the future and make sure that they're able to still perform that procedure, especially if it's a low volume type procedure that may be very high risk. So does that make sense to everybody? Great. So brainstorming, where do we go to get stuff? Where have we all gone to get stuff to work for this, right? I'm sad to say that the people at, you know, the fabric stores, Joann's Fabric, and what's the Christian one? Michael's, and then the other one too, the Hobby Lobby, they almost know me by name going in there, especially since I always buy a lot of the different molding materials, which they don't stock on a regular basis. And so I'll come through and volume buy like 5 bags of molding material, and they're like, man, this is getting really popular. And then they buy 5 more, and then I don't need to buy it for another 6 months. But basically, and we can all talk on this, is basically you're going to go to grocery stores. Anything can be to just to pique your curiosity, to pique your creative juices, as they were, right? Going through Lowe's, going through Joann's, going through these different places. There's local maker / hacker spaces, and so some of these places, some places have downtown areas where there's 3D printers for rent, places that you can otherwise rent time on a 3D printer, and there are people there that are sort of experts, and you bring them an idea and they can actually make it work for you. There's different places all over the place that'll help you with things like 3D printing. A lot of us end up using expired medical supplies from the emergency department, right? Ambu bags, Yankauer tubes, web roll, right? There's plenty of times that I'm using part of it on a patient and part of it for sim lab, and I'm not ashamed to say that. Kind of gather up what isn't being used. I literally have 3 half-used lac repair trays in my car right now. I have stuff here in a box. It just depends on what you're trying to grab. Online, it depends. You can try to find things. We found ballistics gel online that we like to use for a lot of our different sim procedural models, whether it's making a priapism model or eyes and things like that. We use ballistics gel because you can heal it instead of using some of the silicone. So it doesn't matter. Just be creative, right? And start to work with these materials and see if the material is going to work for your procedure, right? So that's the first part of that, is to say that inspiration can come from anywhere. The materials can come from anywhere, right? Your inspiration is your only limitation, okay? And just be experimentation with your inspiration with no limitations, all right? So next. So what are the properties sort of a good model, right? So a good model, again, in a perfect world, it should be cheap, right? If you make a good cheap model, that's always going to be better than a good expensive model, especially from your higher ups, from your sim lab, from everybody. They're going to be like, this is amazing. It does the same thing at $5 instead of a $50. What you should really have is easily available supplies. It's not great if something is going to be on back order, coming out of, some place that only one factory makes X, Y, or Z, and then that factory is shut down for COVID. It doesn't really help you, right? What you want is something that's also going to be easily reproducible, right? So something that you can make and have some standard of measure when you're making it, and make sure that you can make it over and over and over again. It should be easily assemblable and then turnoverable, because when you have your sim sessions, it's not feasible if you can use your model once and it takes an hour to reset it, right? Not everybody's going to have hours upon hours in the sim lab. You want something that you're going to be able to turn over, or something that's easily made and can be expandable, that you can have multiples ready to go, right? So that you can try to attach and have all your learners really start working on it all the times. It's best if it can be done multiple uses of it, right? Meaning it's something that can be used for multiple procedures, or that it can be used in the same session multiple times, and that it has some aspect of procedural fidelity. And again, the point about this procedural fidelity is it doesn't have to be perfect, okay? It doesn't have to exactly look at everything. It really has to capture what is the key part of that procedure, whether it's the feel, it's how it looks, it's what it looks like under ultrasound. You really have to encapsulate what is the critical actions or the critical part of that procedure, and make sure that your procedural model is getting that learner, okay, to that level, okay, and using whatever materials you have that gets there, okay? So if it has to be a disjointed, whatever it is, that sits on a table, great, then that's what it is, okay? And if it has to be something else, it has to be something else. It doesn't have to look perfect. It just has to get that critical part of the procedure. And I hate to be beating a dead horse, but we want you to get over that. Some people get really stymied that they have to make their procedural model look perfect. Like it has to look like a person. It has to look like this. And no, that's not always necessary, right? Because again, half the time when you do some of these procedures, they're covered by a sheet and you only got a little circle to look through anyway. Right? So what does it matter if your whole chest has furry hair and he looks like a Sasquatch and no, you just need what is really critical for that procedure. All right. When we talk about rapid prototesting and beta, unless you want to pass this over to you, Naran, is this me still or you? Sorry.
I can take it. That's fine.
Yeah, that'd be perfect.
So one of the things that we want to talk about when we're creating new models is the concept of rapid prototyping. Now, this is a term that is very commonly used in the engineering industry. And essentially what it means is you come up with a design, you test it, you tinker with it, you show it to your friend, you show it to your colleague, your spouse, whoever. They give you feedback about it. Does it look realistic? Does it look kind of completely off the wall? You take that into account, and then you sort of keep going through these circular motions of iterative design, where eventually you come up with a model that looks okay. You're ready to show it to somebody. Now, who is that somebody going to be? Usually, for most of us, it's our first cohort of residents who will be their guinea pigs, right, for testing out the model. Now, that is exactly what beta testing is. So you actually want to capitalize on the feedback that your first group or cohort of learners will take on that particular model, and then incorporate it into your final model, which would be ready for prime time, if you will. And so that concept of iterative design and building and rebuilding is basically what rapid prototyping is and what beta testing is. And to some extent, we all do this. It's just not intuitive to us to document every single step of how we come by the final product. And if you look, there's so many models out there. And in terms of discussions of where you can go, YouTube, JetEM, and we'll come to some of these things later. There's all these models out there, and the idea is to really use them, build them, improve them, and then give back and disseminate. So going on from here, there's going to be a couple of segments to this, presentation. So we're going to go over some models, which we will present, and then there's going to be a build a model aspect of it. So most of you, or hopefully all of you, have had the chance to get the goodie bags that we sent out. If you registered for the early bird special, we probably had the ability and enough time to make those bags and send those out to you. So hopefully you'll be able to build some of these models as we are progressing along. So at this point, I'm going to hand over to Dr. Roth to talk about one of his models.
So if we go back to what Phil said, this is not a model that is going to have realistic qualities. It looks like a cucumber, but it does serve the purpose of learning the mechanics of how to do priapism, drainage, and irrigation. So with that, let's get started. So it's pretty simple. It depending on the length of your cucumber, you can either cut them in half and have two models, kind of as shown in the top right there. And you simply have the cucumber, and as a model, the cucumber will sit upright. But our goal with a priapism model is that you need to be able to aspirate fluid out of it. And although cucumbers have plenty of water, you can't actually aspirate that water. So our goal is to create a central chamber that can hold some water, and then learners can then insert an 18-gauge needle where they would normally on the lateral aspects of, in this case, a cucumber, to aspirate fluid. So after we've had the cucumber, we core out the center of the cucumber. It's fairly easy to do with a knife. If you have an apple core, it's even easier. You can make that chamber as big as you can while retaining kind of the structural integrity of the cucumber. So you can see that the chamber I've made on the left lower cucumber there isn't that large, and it's because this cucumber was a little bit probably on the staler side. So in true terms, it would be a little bit limp when you put it upright. So for that reason, it has a little bit more of the cucumber pulp in there. So you can see the central core is there to hold fluid. The model, when it's actually in use, is going to be upright on a table. You can imagine that cut surface of the cucumber will kind of self-seal to whatever surface you put it on. For that reason, I would recommend putting in two small slits on either side of the cucumber, just enough to allow fluid to freely flow in and out of that chamber when the cucumber is upright. And with that, we can go to the next slide. So we have this central chamber that allows for fluid to be filled in there. So we need to fill it with fluid. So get yourself a big mixing bowl, submerge your cucumber so it's completely under the water, and ideally tip it up a little bit so any air that's in that central cavity comes out. And then while it's still submerged, either in water or red dye colored water, use just a regular sandwich bag, put that sandwich bag in there, fill it a little bit with water, put the sandwich bag around the cucumber base, and then kind of wiggling out any air bubbles that are there, seal it with a rubber band. And then you can pull it out of the basin of water, and you get what you see on the left there. The finished product, the cucumber can sit upright with kind of a bag of fluid in there. with the rubber band holding the fluid in place. And there's not really enough pressure in there, especially if you use it soon after creation, for the fluid to leak out and cause a big mess. This is what the end product looks like. I simply took a paper plate and put it over the cucumber to kind of hide the bag structure in there. And then residents were able to aspirate on either side of that. And you can see over time, it becomes a messy process. This was after several residents had attempted different cucumbers. And because it's a cucumber, it does not self-seal on its own. So once a resident has done it once on a given cucumber, you can't really reuse it because a little bit of air comes in those holes.
A quick question here, Ben. How long do you leave the cucumber in the dye and water?
So really, it can just be as long as it takes you to get all the air bubbles out and get the bag submerged in there. It doesn't need any additional time submerged. The sole goal of putting the cucumber in the bag in the water is to get rid of any air bubbles, either in the bag or the cucumber, put the bag over the cut end of the cucumber, and then attach a rubber band, all while it's submerged. So it's kind of like the cucumber chamber is filled with fluid, and then the bag at the bottom is filled with fluid, and neither of those have any air, such that when you put it on a table, kind of as shown here, there's a bag at the bottom, a pool of fluid. So when a resident aspirates, they can aspirate 10, 20, 30 cc's of fluid and irrigate it if they want, as we would in a real priapism case. Any other questions? This is by far like the lowest cost, simplest model, and you can make 20 of these in not that much time.
And it's biodegradable.
It's biodegradable.
But again,
Edible,
right, the key
edible.
though is to know where to put the needle, right? So that's why he has a line here to dry for the urethra, right? The key to this procedure is making sure that you don't stab the urethra, right? You have a big zone of opportunity to get in there. So as long as you're in the 10 to 2, right, 9 to 5 kind of area, as long as you're not going to the real clinical aspect of hitting the urethra, you're going to be successful, right? And this still gets over some of the shock and awe value, right? They're going to see a cucumber on the table, right? It's sort of diffusing some of the situation that's in there, because sometimes people start to giggle when they see things like this, right? And that's okay. We're all learners. We're all human, right? We've all been through there, right? But this starts to break down some of those barriers, saying, look, you're going to have to deal with an erect cucumber, an erect penis, and you're going to have to drain it. And that patient is going to be in pain, and they're going to want you to be confident when you go in there the first time, right? Because they're going to be scared. You might be scared as your first time, but if you have this sim model and you know where to stick the needle, you're going to be that much more confident. The patient's going to register that confidence. And this is going to get you to the procedural competency that you need, which is A, stick the needle where it needs to go. That's the critical part of this procedure.
All right, great.
A quick question. So when you make this model, like how many cucumbers do you prepare for a given number of learners?
I do 1 cucumber model per learner, just because the skin of the cucumber doesn't self-seal. So it will allow some air in and allow some water leakage, which is kind of why the table becomes a little bit of a mess after a while. Thanks.
Thank you, Ben. Awesome. I'm going to talk for a little bit about my wearable abscess model. The gap for this really came through. There's a lot of abscess models that people use to teach IND basics, but none of them are mobile. And a lot of them are like chicken or other products that you have to actually keep in the fridge, gelatin, etc. So I wanted something that was mobile, reusable, that was shelf stable. That was my big thing. I'm tired of using my fridge and having to prepare things in real time. And of course was cheap and quick. Next slide. Although I love the cucumber, let me just say that the cucumber is amazing. So for my model, what do we need? So we need some cling wrap. We need, in the upper right is a balloon. That balloon has been filled with a mix of whatever you want to make your pus look gross. Again, I wanted something shelf stable, but can I suggest partially rotten cheeses, perhaps, that might be in the corner of your fridge are actually perfect, disgusting. I've also heard cottage cheese. Not that I've ever had old cheese in my fridge, just a variety of options there, chicken soup with thickener, etc. However, I wanted something shelf stable. In fact, it's been stable for at least a year. I know because I left it there because I wanted to know. But I just use unscented lotion. I didn't want a nice, pretty scent. You know, if anything, you want something a little bit gross. A little bit of water to make it kind of gloopy, and then just a little bit of yellow food coloring or whatever you want. And I took a non-Luer syringe and I just filled up the balloon like you do when you're a kid and you make water balloons and hook it to the top. Okay, and then tied it off. Yes, it can get a little bit messy. Just keep wiping off your hands. The yellow thing is actually one of those really cheap and dirty cosmetic sponge. And I should say everything here I got from supermarket or Amazon. The cosmetic sponge, and all I did is I cut like a little divot in the bottom of the sponge. The big sort of beigeish thing in the middle is my favorite finding last year. It is a tattoo practice skin. These are like pieces of silicone skin that tattoo artists, etc., use for practicing. And then this black item is actually like a little Velcro self-tightening belt that you can wrap around whatever limb you want to practice on. And on the bottom is Kevlar. That's what I started with, but I didn't realize Kevlar. And I wanted Kevlar to protect from sharps, but unfortunately Kevlar is a knit material. So I since moved on to like a pleather arm gauntlet actually. So you can feel like, you know, medieval warrior. Next slide. So what are the steps? The step next to the skin or wherever, I chose arm because I figured that was easiest and less invasive. But of course, if you get materials wide enough, you can put on leg, etc., wherever you want to go. That's up to you and your volunteers. So bottom is either Kevlar, or if you want really better sharps protection, I'd recommend like a pleather or something along those lines. And then cling wrap. This is sort of minimize the mess. It's not going to be perfect. You're going to get messy, but at least it'll help a little bit. Next slide. Above that, so you can see there's a divot in the yellow cosmetic sponge, and there's my abscess that I put in there. Then you just flip it upside down and put it wherever you want the abscess to be. Next slide. And then over that is when you put the tattoo practice skin, and you can actually strap it in place so it doesn't move. Next slide. And then boom, lots of pus, pus, pus. So this is one you can move all over. You can say all those curse words that people say when you try to drain the abscesses. You can, I really wanted them to learn how to position and like reassure the patient and like keep their cool and not like accidentally stab themselves while people surprise them. That takes a little more coaching, but I have to admit, people had a lot of fun. In fact, I tried this one. I wanted to do a randomized study to using a stable like abscess from a chicken breast versus this one, and no one would do the chicken breast because everyone was having so much fun. So next time I have to separate them. But yes, lots of fun. Happy to answer any questions. I'll put my email in the chat.
Any
Yeah, that's a great
questions for
idea.
Stephanie?
No questions in the chat, just some compliments. Hilarious and amazing. Very neat.
Feel free to email me at any time. Thanks.
Okay, Dr. Julie, you're up.
Hello, nice to meet you all. I'm Ian Julie from UC Davis Medical Center, and we have a thoracotomy model that we built a couple years back. I'm going to walk you through it. It takes a couple of steps to really get this thing going, but it's definitely feasible to make it your shop. And we really didn't have much to replicate this procedure. I remember doing it in a pig lab when I was in medical school. It's a good story. I got stoked with pig's blood. And I've tried it on cadavers before, but it's never really felt the same. So with that, let's get moving. First slide here. So what we did was took an old task trainer. I don't know if you guys are familiar with this airway head model. It's an older Laerdal. It's a little bit of a tough intubation, and over time, all these things start to break apart. So what we ended up doing was taking one where the airway was not doing great and using it as the base model for our device. It helps to have any airway model that comes with lungs, if you have one, or if you just have a head that at least has, something approaching bronchioles, you can attach your own bags for lungs and do something similar. This one was very helpful because it was mounted on this really heavy plastic tray, but you could replicate the same thing simply by hammering on one of your other airway models onto a wooden plank. It would have to be something a little on the thicker side. Straight plywood wouldn't really do well just because there's going to be a little torque on the ribs later on. All right, moving on. So here's the end result, kind of. We ended up taking the model, reversing its direction, so we had more tray to work with. We wired through a bunch of coat hangers, is what you can see running in loops around the device. And around there, we hung some yank hours, which really feel a lot like ribs and kind of work the same in this device. On the underside, we have the coat hangers that were placed tied together in a way that actually sustained use pretty well. And we've had this model for several years now and haven't had to replace those. We also hung some wires and coat hangers through the inside of the device. Again, this was a good model because it had those spaces for lungs where we mounted the wire coat hangers through. But again, you can hammer that into your model in any way that you want to build it. Inside, you can see a remaining lung. We kept it on the left-hand side so they could do a left-handed thoracotomy, which is a little more complex. And we internally rigged the different parts. The airway, we took down into a bag, an old anesthesia bag. That's that yellow balloon that you see there to replicate the heart. And the esophagus, we actually managed to run some other tubes through so that we could deliver, a device that kind of looked like an aorta in the back, which was just made out of oxygen tubing, and even a little vagus nerve, which we ended up requisitioning from an old discarded pediatric NG tube. Next. We used an old and rather dirty shin guard as a sternum, which one of my residents had discarded. And if you notice, the model is intubated. The endotracheal tube goes down into the heart balloon that we've placed. So while you're doing this procedure, the person at the head of the bed, who's also the evaluator, can bag the model, which adds a little element of realism, but actually serves to make the heart beat. Next. Great. And then we covered it up with some really simple skin mock-up. That's just a chuck covered with gelatin on which I drew some rather misplaced nipples. We have a lot of better skin models out there now. I really want to check out this tattoo practice skin because that sounds amazing. But there's other things that you can do with silicone. The value of this is we could just whip up a batch of gelatin, throw it on a couple of our chucks, and then just have an easily replaceable skin layer. Underneath that skin layer, which you can't see right now, we have, I believe it was, those movers blankets that are made of that crushed up material. It was thick enough to kind of replicate thoracic, intrathoracic rib muscle, simply because you had to cut through it in order to get access to the internal organs of this device. So when we had our participants perform the procedure, they would have to make the incision through the skin, go in with the proper scissors and cut between ribs, insert the rib spreader, spread the ribs to the side, and they move thanks to the wire coat hangers in a way that allowed access, but not easy access, much like with a real thoracotomy. They would reach inside of the model, move that lung that was kind of flopping around out of the way, and expose the heart, which we were beating using the BVM. The heart balloon that you saw was placed inside of a sterile glove, an expired sterile glove, which was filled with a little bit of fluid to replicate pericardial blood. Really, we had some red dyed fluid in there. We actually filled it up with that pediatric NG tube that I mentioned so that it could be refilled after each one of the sessions. The balloon was sealed and the pericardium was sealed on it by some store-bought zip ties. We have a lot of zip ties in our shop and we use them rather constantly. As the residents approached and moved the lung out of the way, they could find the pericardium, they could find that vagus nerve, they could incise, they would get a nice amount of blood return then, and then they would be able to expose the heart. And once pulled out of the other glove, it would actually start beating rather well. So while not a realistic heart model, it would at least allow them to go through the steps and expose everything.
Quick question. What was the clear material that you were discussing earlier?
Oh, from which part of the model?
Like the superficial skin part, the one at which you drew the nipples.
Oh yeah. So I've used agar gel for a lot of our ultrasound guided procedure models. We tried ballistics gel on several occasions, but because we had to heat it, it was always a little bit complicated to make in our sim lab. So what we've done in a lot of circumstances is taken gelatin, the stuff that you get in large bulk quantities. Doesn't really have any flavor to it, but you heat it up in enough water and it becomes this thick material that you can use as a model for aspiration models. We've used it for a lot of our basic central line trainers. And the nice thing about it is you add a cup of the gelatin to about a liter of water and add a half or maybe a quarter cup of fiber supplement of whatever type. And under ultrasound, it looks a lot like soft tissue to the point where the fidelity is rather good. The value of it is it's really cheap. It's easy to replicate. Over time, it does mold. If you throw in a little antibiotic ointment, it just molds over maybe weeks. If you just leave it as is, bacterial colonies will grow on it over time rather quickly. But you can replicate it and pour it into whatever area, and it dries over the course of a day if it's a large volume container, at least in a refrigerator, or on top of this sheet, it would dry over the course of minutes and allow you to have something that at least texture-wise feels a little skin-like, requires a good scalpel incision in order to cut. But I'm a big fan of that gelatin. It's rather cheap and we use it for a lot of models. The one problem that it has compared to ballistics gel is it's not really healable. And the other issue is that it does have a tendency to core large bore needles. So if you're doing an aspiration model, it can occasionally clog up the needle, so you don't get the aspirate that you're hoping for. Other than that, though, it's a good one.
I wanted to say, if you wanted to see more details of how this was made, the website below, I think it's still active, and you should be able to get more details on there.
Yeah, it has a step-by-step guide, and then it'll have a video of the device in use. But with practice, we were able to use it for 4 concurrent sessions. It takes about 5 to 10 minutes to restock between users. And we got our trauma surgeons and our emergency medicine residents through it a couple of years in a row with some pretty good results.
Just like one quick comment to follow up on Ian's excellent demonstration and presentation. You notice that Ian talked a lot about sort of expired products and stuff. If you don't already do this, develop a relationship with your supply center, the ED supply center, to kind of hand you over expired materials, so that way you can sort of sift through them and have supplies that don't cost the hospital any money to use for building these models. Some sim centers actually have a relationship with the hospital where all the expired stuff goes directly to the sim center. But those are great stores of supplies for getting stuff to kind of fiddle with and to develop these models. So obviously go to your Michaels, but the ED is you can really play around with that stuff.
Quick question, what's the recommended brand of gelatin that you use? I feel like there is some variability.
I will have to find that and let you know.
No worries.
I can probably find a model online and let you know the exact brand.
So my experience has been we've used regular Knox model, Knox gelatin, and it seems to work pretty well. We've used that a couple of times.
Yeah, we have the cans of it, which can here we go. I'll send a link. Unflavored gelatin, delicious. I'm sorry that the Atavist site is down. I'll have to find another way to share this model with you. But as Charles was saying, having a good relationship with our whole hospital in terms of a more or less waste dump is really, really good. The big problem that you'll occasionally encounter is that people will bring you a bunch of stuff that you really don't need. So it's nice to find a way to filter and pick through the material that they have that's expired and choose what you need before it goes to their regular disposal process, rather than you being the regular disposal process.
Awesome. And then also just want to point out one of the items that was shared here, the silicone food safe baking mat as an option for skin, which is a great idea.
Absolutely. All right, any more questions about this one? Okay. All right, why is this not working? Let's see here. Okay, I'm going to go over 2 models fairly rapidly, and these have been around for a while, and they were published in 2017. So the first one is a peritonsillar abscess model. So what you see over here is basically bubble wrap, the big one, the 1-inch kind. And you essentially take it, you cut rectangular strips out of it. You take 2 bubbles, which are about maybe 4 to 6 inches apart, and you leave those intact. Everything else you trim away, and then you thread a zip tie through both those bubbles, shown right over here. You essentially take any amount of, chicken soup or something of that nature. Make sure that it doesn't have any pieces of meat in it, so it'll get stuck otherwise. And you fill those bubbles, pretty much shown like here. Then you take some Gorilla Glue and seal each pocket. Once it's dried, once the glue has dried, you essentially take liquid latex. You can get flesh colored or different colors, it doesn't really matter. You essentially put a thick layer of liquid latex on it and you let it dry overnight. That's what I do, 6 to 12 hours for a minimum. And then you could pretty much lift the entire product off your aluminum base and then squeeze it into an old task strainer, which is showed right here, which allows you to really practice, doing the actual drainage. And the thing about it is because the liquid latex, if you put a thick enough layer, you can actually get multiple hits from it. And so for each model, you can safely get at least 4 learners to practice doing the procedure, which I think is a pretty good way of doing it. If for some reason you don't have an old airway model, you can always use like one of those disposable cups and put it in there for practice. The next model I wanted to quickly go over was a perimortem C-section. I think this will look familiar because this was presented earlier in one of the workshops. So this is a model, and I know that there's some more innovative and newer models out there, but this is what we put together in 2017, and it's been replicated by some of our collaborating sites. But basically, it's a cheap baby doll from Walmart where we essentially use an umbilical cord, which is heat shrink tubing into the belly, and then put the baby in a Ziploc bag, put some water in it, and essentially zip tie that all together. And you fashion a uterus out of a carpet liner and spray paint it, and then put all of that construct in the casserole, the turkey casserole, and then you cover it pretty much with a silicone or latex and a gelatin layer. And now this is very similar to what Ian was showing on his thoracotomy model. This is fairly similar to that. And then when you cut through it, you're able to basically use the baby and get the baby out from there. So that's kind of what that model is. Can start. I think from here on, we're going to go to the actual, build a model. So what I'd like you all to do, for those of you who actually have the little packets with you, go ahead and start assembling the models as we are showing them here. So I think this part of it, I wanted to be more interactive. I wanted you to take the time to actually build the models as we were doing it, just so that you could get a sense of what it is, like the kinesthetic aspects of what it is. And I think it's fun. So, all right, over to Charles.
All right. The model that I'm going to discuss is the cricothyrotomy model that we made. And don't get me wrong, this is not the only cric model out there. There are a lot, and a lot of them are very good. So this is definitely, I'm not saying this is the best, but it is one possibility. Next slide, please, Naren. So these are the materials that you would need to build this model. This staple gun and the board are optional. They're actually the 2 most expensive pieces of this. And the only reason why we use it is it allows us to mount the cric model onto something, but it's not necessary. Everything else here is extremely cheap. The corrugated respiratory tubing is, the one that the kind that you can get from the emergency department, and one, set of them will give you, I think, 20 something models. Foam cushioning you can get from Amazon, 75 square feet is about $12 or $13, and you just need 1 square foot, and you can do this procedure a number of times. And then the rubber leg tip, those are 50 cents a piece from Amazon, and each one of them will create 1 cric model, and each model you can use hundreds of times. So that's what's really nice about this. And then I don't know if for those of you who did get the equipment in the mail, if you do have kind of cric equipment like a number 10 blade, a bougie, and a scalpel, and a 6/0 ET tube, please follow along. Otherwise, you can still build the model. All right, next slide, please. So I'm just going to discuss real quick the steps, and then we're going to go through them one at a time. So the first step is to take your rubber leg tip, one of these, and make a 1 centimeter thick ring, cut off a 1 centimeter thick ring from the open end. And so what you'll get is something like this. So your rubber leg tip, the tip of it, and then a ring right there. And so the tip is your thyroid cartilage, and the cricoid cartilage is this ring right here. All right, next slide. And then you're going to take your corrugated respiratory tubing, cut off a piece of it, maybe like six inches long, something like this, and then insert the ring through the corrugated tubing. And so I'm not going to do that here since I have a finished model and you guys may have it in front of you. But then what you're going to do is after you put the ring through, you're going to take the end of the tip of the leg tip and then put it on the end. So it ends up being something like this. All right. And then right in the center, you'll cut an opening in that plastic, just like that. You can see it just like that. And so what happens here is you have your thyroid cartilage, your cricoid cartilage, and this is where the cricothyroid membrane would be. And what I like about this model is that this thyroid cartilage is not it's not angulated, sort of like with a prominent Adam's apple, because this makes the procedure actually a little more difficult for you to actually palpate the thyroid cartilage. Next slide, please. Great question. It's a 1 inch, I believe it's 1 inch. It's the standard respiratory tubing for your ambu bags, but it's about, I think it's 1 inch. And the tubing I didn't get on Amazon, but you can get it at any sort of medical supply store or at medical supply site. It's like $1.50. And I'll put the link for the rubber leg tip on Amazon, but I think it's a 1 inch internal diameter. All right, so what we do most commonly here is we'll staple the end of the model onto a wooden board, but I'll show you in just a second how you can, kind of attach it in various different ways. Next slide, please. And then you'll cover the model with a piece of masking tape that serves as a cricothyroid membrane. Then you're going to take one of these foam pads and cut them into little strips. And so I have a bunch here, you can see. And each one of these strips serves as one cricothyrotomy procedure. So you'll fold it in half and then put it over the piece of tape. Next slide. That serves as the subcutaneous tissue. So you can add more if you want to make the neck more thick, or and then put another second piece of masking tape on top to cover everything else. All right, so I'm going to do this. I'm going to do the procedure right now. And so I'll show you. So for those of you who have the kit at home, you should have already gotten this. I kind of pre-made it for you just because I didn't want you to cut yourselves while trying to do this in live. So you should have the rubber leg tip already cut with a 1 inch or 1 centimeter diameter or 1 centimeter thick ring. And I've cut that middle piece open for you. So what, since we don't have a staple gun, and actually you don't need one, you can actually just put it on any hard surface. So I have a table here. You can put it on a clipboard, which I have here, a different model right there. You can put it on the wall. So I've done it where, in sort of just-in-time teaching, or in the ED where the shift is a little bit slow and I have some time, I'll just kind of, I'll just mount it on the wall sometimes, right? You can do that. All right, so we'll take a piece of masking tape, and you guys, for those of you at home who got the kit, you may have gotten some masking tape on a syringe. That's the masking tape that you can use. If you guys have other stuff, that's fine too. But so you go ahead and take your masking tape and put it down like this, and just put a piece and tape it to the table, right, like that. And that, again, that's your cricothyroid membrane. And then again, we'll take a piece of this sort of foam padding or foam cushioning and put it on top, and then a second piece of masking tape on top. And that literally is that's the model right there. So it's very easy, it's very cheap, and the procedure is very quick. And I think the thing with cricothyrotomies is we don't do them very often, right? But we want our learners to develop a sort of do this repeatedly, time and time again. And this model allows you to do that, kind of reset it real quickly and then do it again. So for those of you who actually have the equipment, I have my number 10 blade, I have a 10 cc syringe, I have my 6.0 ET tube and a bougie. So I'll just kind of show you guys how I do it. You guys know how to do the procedure, but it just sort of, the model is just kind of I'll just kind of show you guys how it's done here. So this is tape, you can tape to pretty much anything. You make the incision just like you would. You put your finger in, make a stab incision into the cricothyroid membrane, right? Extend the incision, make it a little bit bigger. Put your finger through the hole, right? Dilate the hole. I'll take my bougie right now and just stick it in. And then load my 6OT tube, right? And there's your procedure, and there's your cricothyrotomy. So what's really nice here is you can actually, as the instructor, I can actually see them inflating the balloon in here, because you can see the balloon go up within the respiratory tubing. And then, once I'm done, I can actually reset it very quickly. So I just take everything out, pull off all the tape and everything else. I didn't really cut any of the plastic, so this entire piece can be reused. And then again, I just reset it. So when we do our kind of airway labs and stuff, we'll use this model, each model like hundreds of times. And when I for this SAEM talk, I built 40 models to send out, and that took me about an hour to build all 40 of those models. So that lasts pretty much forever. Next slide, please. So the advantages, again, this is really inexpensive. The most expensive equipment is probably is the staple gun. Everything else is like, this is 50 cents. This is like $1.50 for a lot. And then it's very reusable. We've had the same models that we've used for like a year or two, and then we just they get kind of beat up as you keep taking the tape on and off. And so we'll throw them out and make a new one. But one of these lasts for a couple of years. I usually have one of these in my ED bag. So when I bring it to work, it's slow shift. I'll just take it out. We'll do a few crikes. It's really easy. And then again, it's really easy to turn over. It's fairly realistic. Obviously, it's not 100% in terms of fidelity, but as we talked about earlier, as Phil talked about, you have to align the procedure and your model with your learning objectives, and the learning objectives are for our learners to know scalpel finger bougie, right? Scalpel finger bougie, just do it over and over again. And so with this model, you can just do it, reset it, do it, reset it, do it, reset it. And we've used this as just a standalone trainer. So just kind of, put it on a table or on a clipboard, and it just sort of stand alone. We can actually adapt this to an airway head and just put it on the neck piece. We've actually taken off the top or sort of cut off the top here, and then kind of extended the tubing past it, and then actually attached it to an ambu bag, and you can actually bag. And if you add if you add some tubing in here, you can actually cause blood to squirt out as you're bagging, and so that creates a realistic bleeding, just an angiocath, just either through the bottom or out the side. And then we've again, we use this in the ED. We have a sort of a procedural kit that we have in the ED that's just for procedural training, and we just pull it out, and you can do a bunch of crikes on an easy shift. So I'd be happy to answer any questions about this model.
We actually have a couple here. That was great. Thank you so much for presenting. First question is, what size is the tubing diameter?
Yeah, the tubing diameter, I think is, I want to say is 1 inch. I can't say, but I know that the internal diameter for this leg tip is 1 inch. So I'm assuming it is the same thing. I don't know that that's how it's measured, but it's the standard respiratory tubing that you'd use for your ambu bag in the emergency department. So that's where I got it. And I can send out the link for this because there are different sizes.
Yeah, and then they were also asking for Amazon link for tubing, if you don't mind. Thank you.
Cool. I'll send it out.
So since we have people actually hopefully building some of these models, would anybody like to share what they just built? Hopefully, maybe. Brave enough to put it on the camera? Anybody?
We have another follow-up question also while folks are deciding whether or not to show their models. When did you use the stapler?
Yeah, great question. So I didn't use it just now because the stapler is just one way we attach the model to a surface. So if I had a stapler, I would attach sort of the inferior piece to the wooden board, and just so that this part is mobile, the top part with the thyroid cartilage, but the inferior part would be stapled to a board. But when I'm carrying this around, I really just carry around the minimum, which is just the respiratory tubing with the rubber leg tip on it. And you can attach it to anything else with the tape that you would use to create the cricothyroid membrane. So again, the tape serves multiple purposes. What I like about this, so I don't know if you guys can see my screen, but what I like about the clipboard is that if the clipboard actually just it kind of adds a little bit more fidelity to it just by saying this is the head, right? So, you know, I just know this is the head, this is the foot. So when they come and look at this model, they're not just like, what is this, right? I tell them, you're doing a cric on this. And so they know to rest their hand on the patient's chin, right? That's right here. And they do the rest of the procedure. So in some ways, you don't even need this, kind of not using the stapler might actually be better.
So one of the things that I wanted to ask you was if you've tried, instead of the masking tape, have you tried doing this with a foam tape? Because sometimes that's a little bit, I guess probably more expensive, right? But has a little bit more kind of tissue-y feeling to it, I guess, or if that makes any difference.
It's a great question. We've not swapped it around, and I think you can make a lot of edits to this one. We've, you know, you had, earlier on in your talk, Noreen, you had mentioned sort of doing, you know, it's kind of this rapid prototyping. We've done a lot of prototyping with this model and kind of, you know, kind of simmed it up to various degrees, depending on what kind of fidelity we want. Obviously, it gets a little more expensive that way. This is what I presented just now is the bare bones, like cheapest, quickest, you know, turnover model, but we have a much more sort of like high fidelity model that has all the sort of bells and whistles of the bleeding and the breathing and all this stuff, all based on this sort of like, you know, underlying, you know, structure.
That's awesome. How do you do the bleeding? Is it like, do you connect it to like a little tubing or something and just sort of?
Yeah, we just literally just run an angiocath up this way, like tubing, and an angiocath up here. And then there's someone like hidden that just squirts a bunch of blood as they cut through. And also if we hook it up to a mechanical ventilator, it will just squirt blood. That blood ends up becoming aerosolized.
That's awesome. I think that the part about it that I really like is the fact that it's so portable and the fact that you can actually take it for just-in-time training. Because, you know, my experience with a lot of the sim procedures is that the more you do just-in-time training, you know, the better you're able to actually perform some of them. And crics are one of those things where, you know, in the ED world, when we're trying to learn about advanced airway, all of us really need to know this like the back of our hand. So I can't say, you know, over-learning, the more you learn, and the more you practice, the better it is. And the fact that it's so cheap makes it, you know, extraordinarily useful, at least in my mind, because we always have limited budgets for that kind of thing. All right, so yeah, so Shayla, thank you for offering to share your model. I'm really excited to see it. And hopefully we're going to have some other folks who are also building this, because I know that some of the other folks had mentioned that they had received the packets. Perfect. There you go. There, oh my gosh. Hey, that's an idea. That's an idea. That could be real high fidelity right there.
Charles, that was awesome. It's Yui, by the way. One of the things that we had talked about from our side, I'm in the peds ED, is for whatever odd reason, we've had to risk doing needle jet ventilation on 2 kids in the last couple of weeks.
Oh, whoa.
But Vanderbilt has access to, I think someone mentioned it earlier, are the 3D printers. And I had a friend of mine build, and the cost of making an actual larynx now, an actual like mock-up of a larynx with a 3D printer is like $2 to $3.
Wow.
Just the material to print it, and it actually looks like the real one. So we were able to kind of modify the anatomy to look like a pediatric airway.
Nice.
But again, I know we're talking about low fidelity, but now with the cost of 3D printing being so low, we can print out like a bunch of different larynxes for different sizes of kids, and kind of use the same mock-up. And I like Charles' idea of just like quickly take the tape off and put it back on, and you can reuse it multiple times in the same setting. That was great. Like it.
That's amazing. That is amazing.
Congratulations, by the way, on the new baby.
Thanks. Yeah, and actually that's a great point, because with one of our sort of like higher fidelity models, that's exactly what we use. It's a 3D printed, you know, cric that feels and looks more realistic. But again, if you don't have access to it, this is sort of like in the moment. But I think 3D printing has come a long way, and it's super cheap and accessible now.
Yeah, I think you're able to do a lot more with 3D printing now than you were even a few years ago. And I, the 3D printers in your homes now, whereas before they were only in, fab labs and whatnot. But I think that's a fantastic way of utilizing it. And if you don't have your hands on a 3D printer, reach out to your Department of Engineering. Trust me, they have it, and they're going to be happy to help you. And especially if you have like any kind of summer interns going around your shops, like these guys are phenomenal for coming up with really cool models. And so just as a side note, to kind of put them on those. All right. Any more questions? You know what I was going to see? Oh, there's a comment over here about flight programs. 3D printed larynxes and super cheap, very realistic. Yep. Yeah, absolutely, Kelsey. Absolutely. I was going to see, because I know that Shayla had said that she was going to try to bring her model, but I don't know where she went. Is she still here?
I'm
still here?
I'm here. It just says, I don't know. It says host has asked you to start your video. Okay. It just said that the host stopped it or something. I don't know what happened, and I can't see.
We see you. So if you pull
okay.
up, yeah, I can see you. So if you pull it up, we can probably see you. Yeah, there you go. Perfect.
So you can get this like flesh colored duct tape kind of paper tape. So I buy a lot of this for other models, so I just have this. This is my office at home, and there's boxes of garbage here like that we use, and so I just picked out what I have. So I just used that, and I had a needle, and so
Can you raise it up a little bit higher?
Oh, sorry.
Perfect. Yeah. That's perfect. That's awesome.
But yeah, I mean, so I was looking at 3D printing, and we don't have one or access to one right now. So we were thinking about, we didn't want to buy a bunch of pig tracheas. It's messy. So I was looking for, there are some other options of like making these low cost ones, but I really like this one actually. So I think I'm gonna totally steal this idea. And do it for our interns, and then we can get our medical students to make a bunch more. I think that's going to be awesome. Thank you so much.
Awesome. Well, thank you for sharing. All right. So any other comments or any other questions? Anybody else willing to take the leap of faith and show us your models?
I was just going to say also, if you have access to like an undergraduate institution that's through there. Like I've teamed up with Clemson University for several other things. They have entire engineering departments that would love nothing better than to have some sort of a medical application. And so many of them need undergraduate or graduate products and projects and things like that. Like we recently published on a mask recycling paper with them, right? And so there's plenty of engineering departments as well if you don't have access to it, and they'll sit up day, night, weekends trying to make this stuff work. So you don't even have to have it through your medical school. You can have it through some of the undergraduate institutions as well.
All right. Okay, Ben, you're up. Hello. Dr. Roth, you still here?
Sorry. I'm here. I apologize. Next, we'll talk about an eye foreign body removal model. And similar to the prior model, it has the benefit that once you've made it once, you can reuse it multiple times. So with that, we can move to the next slide. Great. So in your kit, you should have gotten a little packet of ballistic gel. We don't get any money from these people, but they are in our local area, which is why I use them. Your packet should also have a teeny tiny little eye, like you can see here, and then a small mold. So kind of at this time, if you plan to build along, now is a good time to start heating up your gel. And what I mean by that is kind of the other supplies that we couldn't supply you. Go ahead and turn on your stove or hot plate, kind of a low to medium setting. Put your ballistic gel directly in a pan on that hot plate, and it will slowly start to heat up and melt. It'll take a little bit of time. And so that's why we'll go over the procedure kind of as the gel starts to melt. And you can just literally take this hunk of gel out of the bag, plop it right on there. And if you stir slowly, it'll melt a little bit faster because there'll be better heat transfer to it. So after our gel is kind of a nice fluid consistency, we'll plan on pouring a little bit of the gel into our mold. Then what I mean by a little bit of the gel, we really just want a small amount of gel in there, essentially the size of a cornea. And then you can take that teeny tiny little iris. How about you just keep that down? Okay, sorry. You can keep your teeny tiny iris and put it into your mold in face down on that corneal sized amount of gel. Sometimes this is aided by either tweezers or hemostats just because the gel is hot. Once that iris is sitting on that gel, you can go ahead and fill up the mold with the remainder of your melted gel. And this amount of melted gel probably will make you 3 eyes. So it's a good amount of gel.
Do you want me to progress the slide?
Yeah, after you wait probably about 10 minutes, the gel will be cool enough to pop out. And the benefit, this is one of those edible silicone, not food safe silicone baking sheets that I simply cut up. So if you look at the larger one, I cut the silicone baking sheet. The benefit of this is it's flexible and you can just pop out the gel with your thumb. But it's got to be dry before you, or cool before you do that. Otherwise you'll have a permanent indentation. And then once you have your dried, cooled gel model, you can add whatever foreign body to the surface. You can place whatever foreign body to the surface you want. So next slide, we'll look at a couple pictures of this before we actually make our model. And just as a warning, the gel, as it warms up, starts to smoke. And it's kind of temperature dependent. So you can get a liquid gel that is not yet smoking. But if once you go above a certain temperature, above like 250 to 300 degrees, it really does start to smoke. So there's a benefit to doing this either in a large open space, outside. I normally do it in my garage. We did it in the sim lab once, and it does make the whole area kind of smell. And the other thing to note, because the gel gets to that 250 to 300 degrees, it's hot. So if it gets on your skin, it will burn you. And somewhat counterintuitive, I mean, it makes sense after you've done it once and seen the consequences, but you can't add certain liquids to it. For example, water. If you add anything water-based, like a water-based dye, it will generate bubbles because that water-based dye is gonna boil and bubble. So if you plan on coloring the gel at all, you need to use a specific type of coloring. I think this company kind of advertised their own dye colors. You don't have to use these. Amazon has something very similar for cheaper that are just silicone color dyes. And we can probably buy Smooth On. If you search Smooth On silicone rubber color system, you'll find a wide range of colors. All right, with that, we can move on. So this just kind of shows that melting process. You can move it slowly. You can see on that far right picture, I was maybe a little bit too aggressive with my stirring and generated a lot of bubbles. So I think in my next slide here, I should say bubbles are your nemesis. And I mean that seriously because they kind of ruin the way a model looks. Yep. So this just shows that initial step. We're going to pour a little bit of gel into the mold. And so you have a cornea-sized amount of gel in the mold. Next, we're going to place the iris on top of that cornea-sized amount of gel. Next slide. Just like that, while it's still hot. Then we're going to go ahead and pour the remainder of the gel on top. You can advance. Perfect. So you can see I kind of covered the top there. You'll also see that I poured while it still had all those bubbles. So that's why it's so bubbly in there. Next slide. So this is me pulling it out. You can see that it wasn't quite cool enough. to pull out yet. And that's why it kind of has that little crinkle developing. So you really got to wait for it to cool. One of the ways that you can kind of speed up the cooling process is that you can get a small cup of water and just let the mold float in the water. All right, next slide. All right, and these are two examples. The one on the left there, you can see has tons of bubbles. The one on the right has fewer bubbles. Really, the only difference between these two eyes is that one, I corrected at least some of the surface bubbles with a heat gun. So I kind of took the heat gun just to the surface. And a heat gun you can buy at Ace Hardware. This is my heat gun for about 20 bucks. And it really can generate a good bit of heat. So about 5 seconds of the heat gun smooths over the surface. So we got all those surface bubbles out. And then you can see in that center picture, the left side has some pepper sprinkled on top, which actually serves as a great foreign body example because it sits almost flush with the surface of the eye. And then as well, it can easily be removed with like an 18 gauge or a 21 gauge, whatever teaching technique you want to use. And then on the right, you can see I took tiny little pieces of wire and just kind of put them on the surface. And you can even have them go a little bit into the cornea, the way some of our metallic foreign bodies actually do, that they penetrate the cornea. And so they take a little bit more effort to remove than more simple surface foreign bodies like the pepper. Next slide. Great. So if you get a whole lot of bubbles, as shown on the left there, if you just wait and remelt, those bubbles will go away. Likewise, as shown in part 2 there, like all those surface bubbles can really disappear just with a simple heat gun. But it's impossible to get rid of the smaller bubbles within there, and that's why it's better just to wait and remelt. All right, and with that, if you guys want, we can make the model here. So, yeah.
Hopefully you guys have like something to heat it up and make it. But follow along with Ben. One of the questions I had, Ben, so you mentioned the food coloring or the silicone coloring. Is that something that you can just add to the ballistic gel directly and it'll?
Yep, you can add it to the ballistic gel directly. You can either use kind of this silicone rubber dye and just add small amounts at a time. It doesn't take a whole lot to generate a good bit of color to the eyeball. So just kind of go slow, add it slowly until you get the right tone. Whether you're going for kind of a skin tone or an eye tone, not too much will generate the color that you need. You can also use some powdered gels, like powdered colorants. Those will work as well. They change the ultrasound properties of the gel though. So I think Shayla had mentioned using ballistics gel to ultrasound eyes. Just be aware that some of the powder gels change the ultrasound properties of the ballistic gel.
Okay.
Any other questions before we get started?
You guys should know that ballistics gels, they come in different consistencies. From that one site, they have different numbers based on how quote unquote thick they are, right? So some of the numbers will be more rigid as it were versus more soft, right? And it has to do with the amount of the consistency, right? So you can always try to get several different numbers. They come in numbers like 1 to 4, 1 to 5. And so that always makes a little bit of a difference.
I have another question for the group. I don't know if anyone will know the answer to this, but I've used ballistic gel for a variety of models before. And, you know, it always says to heat it in like a well aerated space. I just have my small apartment and just heat it here. Does anyone know like how toxic the vapors are that are coming off?
It's not. It's actually FDA approved for use in preschools. You can eat it and it doesn't cause any bit of an issue. So it is completely non-toxic according to the maker and designer of it. It uses biodegradable materials over time. And like I said, they even had it FDA approved for use in preschools for like toys. Like you can eat it and it just causes you a little bit of some loose stool, but that's about it. Not that I'd recommend it and I haven't tried it, but truly that's what it's meant for. The smokiness and everything there is just really, it's just a little bit noxious, but it's not toxic.
Okay, it's not toxic. Oh, that's very helpful to know. I really appreciate
But it does catch fire, and if you leave it out on a sunny windowsill, it will melt as well. I'm just putting that out there. You can't leave this stuff out in the sun; it will melt.
Yeah. So with that, if you take a look at the pan here, the gel is melted. Again, I don't have it super melted, in part because I want it to cool fast enough to extract from its mold, but also I don't want to smoke up my house here. So kind of as we described, we're going to take a little bit of the gel and just pour it into the bottom of the mold. And like I said earlier, I have the mold floating in a little bowl of water here to kind of speed cooling. So I just put a little in, and I'm going to give it a second to kind of flatten out in there. And then put the iris kind of right in the middle there. And again, you could do this with your hands if you wanted, but be careful not to touch the gel. So I'm a little bit off kilter because I didn't have it centered, but that's the one disadvantage of live streaming. You can't redo everything. So, and then just slow pour all in one spot to prevent other bubbles from coming up. And you can see this one has many fewer bubbles than the example I showed you. I kind of poured a touch too much, so it's running over. A good life lesson here, if we look at the pot is dripping. And so these drips, when they hit the heated coils of the hot plate, will immediately start to smoke. And when Philip was referencing things catching on fire, this is how they caught fire, because it's very hard to pour perfectly without causing some drips. And so even though I have the hot plate off, you can see that it's actively kind of smoking where it touched the coils there. And so now we're just kind of in that process where we've just got to wait for it to cool. The benefit is you can almost even submerge it in water because
it is hydrophobic. It is 100% hydrophobic. It will not absorb water.
So that'll help it cool. And so the edges, I can already feel that the edges have hardened, but the center part here, I don't know if you guys can see this, but if I pick it up, that center part is going to generate a divot. You see how it has a bubble there already, and it's still fluid on the inside. So you really want to let it cool off enough that it doesn't cause you to misshape it as you pull it out. Kind of while we wait for that to cool, I will show you a couple other examples. So Phil made some fancier eyes here that you can see where he actually used the colorant. Sorry about that. The colorant for the white part of the eye. So he used the clear gel initially, did a pour consistent with the size of a cornea, put the iris on, and then used the white colorant from the same silicone color pack that we discussed earlier, and that helps color it. So he made kind of a separate amount of just white gel that he can remelt and then make more eyes if he wanted to. Likewise, one of my earlier models here, you can see you can mount these. And so you can see my earlier model didn't have any irises, didn't have any white coloration here. Literally what I did was I put nails into a head and then used the nails to insert into just a styrofoam head. And that way it increases kind of the feel of the real procedure, because you have to brace your hand against the head's cheek or chin to use the 18 gauge to kind of pull out any foreign bodies there.
Wait, can I ask a question? So the nails are going inside the ballistic gel, it's not ripping it up?
Right, yeah. And so that's the benefit of ballistic gel. It can do crazy stuff. So after it's dry even, I put these nails in. They literally just slid in. And I think I even put them in through the front because I don't have an iris here. So I literally just put it through the front and then used the heat gun to heal the hole that was made. But even already the surface is relatively smooth, even without using a heat gun to seal that surface there.
Oh, that's awesome. That's awesome.
So I think our eye is probably getting pretty close to being done. It's probably still a little bit soft, but you can see that the eye, my cornea was a little off kilter. Like I said, the downside of doing it live stream that you can't correct the problem. And if you notice, the surface has a slight irregularity where we made that initial cornea followed by the larger pore. Like the larger pore is perfectly hemispheric, but there's just a slight ridge there. You can literally take your heat gun, about 5 seconds of heat will smooth that over so it will all be perfectly hemispheric. Likewise, now that you have this, you can take any foreign body, whether it's pepper like we talked about, or metal shards or wood foreign bodies. You can take any foreign body, put it in the surface there, let residents dig around in it. The surface is going to look terrible, but then you just take your heat gun once they're done and heat gun over it, and it will be perfectly smooth again. Eventually, after you've done the heat gun so many times, this nice hemispheric shape will start to flatten, but you can get many, many uses out of it before you get to that point. Any questions about the foreign body model, how to do it? Did anyone try to do it kind of as we were talking here?
Would love to see it. If anybody tried to tinker with this, even before this started or try to do it right now, please share. Please share your experiments, if you will. We'd love to see it. And even if you don't, if you don't have the requisite equipment, if you do make it, we would love to see how it turned out. So just, tweet it out or something, and just sort of hashtag Take and Bake Sim Academy, so we know that that's what it was. But yeah.
Hey, it's Shyla. I had an idea. I've never worked with ballistics gel, so I was really excited about getting this in the mail and like learning just about how to use it. I had an idea. Our residents are really interested in learning like regional anesthesia, and there are not a lot of great models for that. But I feel like if we put like some like angel food pasta in like a thing of ballistics gel with maybe like a couple of tubing to be arteries and veins, that might be an interesting task trainer to make for like an anesthesia. Has anyone tried to do something like that? I think that might be pretty. I'm excited to experiment with it. I don't have everything ready here to do this in my office, but this is like super exciting.
So I
can comment on it. I actually used it for, I presented this at IMSH, but for serratus anterior plane block model, use ballistics gel. What's nice is that like the haptics feel pretty similar with a couple additional layers, and then you can actually do it under ultrasound guidance. I would say the drawbacks is I tried to do several iterations of the model with putting stuff inside the ballistics gel, like Easter straw and like a variety of other things. And that piece didn't work out as well because it disrupts your ultrasound visualization because I think it introduces air perhaps. So that was like the main drawback, is not being able to put something in it. So I really want to create muscle striations and vessels. It just like wasn't as easy to do as I would have liked, but I'm sure of just a few more iterations and you could.
We played around with the ballistics gel and our Knox gelatin quite a bit. With Knox gelatin, you can layer in basically latex tubing. Again, go online, search for it. If you get like 1/2 inch diameter or 1/4 inch diameter latex tubing, you can pull it through a Tupperware thing and layer in whatever vessels you need, and you can put in nerve. I like old Ethernet cables because I have a bunch of them, and it's so old school, but it looks relatively good under ultrasound. Ballistics gel, from what I found, if you put in something rigid to make a vessel and then perform the procedure with it in a water bath, you can get slightly better vessel replication. But leaving in tubing or anything like that doesn't work particularly well. And the ballistics gel has a slightly different ultrasound resonance, I guess, so it scatters the image somewhat more than a water-based gelatin, but it's still definitely good enough for visualization for, like, you know, kind of invasive procedures that aren't too deep.
Yeah, we do it a lot for our ultrasound guided IV trainers and stuff like that. So you pour,
Nice.
and then what you do is you'll take a Tupperware, you know, and cut some holes in it and pull the tubing through and then pour it through, right? And if you have some liquid going through the tubing at any one time, it'll keep it puffed up, you know what I'm saying? So you actually pull the tubing and tie it off, and it'll also cool the gel faster around it so you won't melt the tubing. And it really depends on, you got to be a little bit of a candy maker with this stuff and get it to that right temperature and the right consistency so it'll pour. The other thing is trying to make skin and stuff. We do a trainer where we do regional nerve blocks of the face. And so, you know, we basically embed wires and metal plates in your supraorbital, infraorbital, and the mental, and then attach it to a broken up game of operations so the head shakes and vibrates when you get to the right spot. And what you have to do with that is that you'll have to pour the gel over it. Okay, to kind of let it layer and stuff like that. Otherwise, if you try to dip it and do all this, it's kind of harder. If you want to get layer after layer, you get it to that layer, and that was one of the big tricks for us, was to try to make skin and try to get skin to cover the face. The real trick was otherwise pouring it. So you're going to need a fair amount of it to kind of get in there and either dip it and pull it out, or just pour some over the top and let it pour, and then just cut it and make it look pretty around the sides. The cool thing about the ballistic gel as well, especially for some of the procedure models like this, is once you have it made and you have a good skin, you can heal the track marks, right? And so you just heat gun over the top of it, right? And they can't see the holes anymore, right? So that way, for that one, it's pretty good. And then the other thing we use it for too is to make our other priapism model too, is using that for sim, right? And so you make a model like this. Sorry, I don't want the kids. So, but basically this then fills up, and we fill this with betadine, which looks really great as deoxygenated blood, and ain't nothing going to grow in straight betadine. So it does stain, but it's something that you can otherwise fill up. And so the way this works is you just make a really thick base, and then you can fill it up again through there, drain it, heal it, and then go back through. So Ben's going to bring up some of the other models that we have. He's going to show you the face model right here that we have, and then he also makes a knee aspiration model as well. So this is the face model that we have, and then this is a bust you can buy from Amazon, right? It's just a plastic bust, and then you just pour the skin over it. And what you do is you have it connected inside there, and there's the battery game and everything, and then you just get to the right spot, and like you can't see it, but it shakes, you know. And so I think the battery is actually dead. But basically, you get your supraorbital, your infraorbital, and your mental blocks, and then it kind of works for that. And then he has a knee aspiration model as well. So
yeah,
this is
that's amazing.
Epitome of homegrown. I took like a $30 Amazon knee model, like the bone component of it, and then froze some balloons filled with water to generate kind of the joint space with fluid in it that I had put a little yellow food coloring in, and then pour the hot gel over top of it. And so this works for actual aspiration. This is a little bit less reproducible than I hoped it would be, in terms of after you use it for a procedure session or two, it starts leaking fluid because they poke too many holes everywhere and you can't heal all of them. I'm still working on a solution for that.
Yeah. That can definitely happen too with the priapism models too, when they suck them dry, as it were, and then you try to fill it up again. When you try to heal it, if you use your heat gun a little too aggressively, this, depending on how thick you make the skin, it may burn through, so to speak, right? And make it really, really thin. So this is why I always have other ones otherwise made. And you can make them in any skin tone you want. I have another gentleman here, but basically, that's the other part too, is that you can add the dye and get any kind of skin tone that you want. This is some of the flesh ones, but like I said, you can, whatever you need.
Any other questions?
Oh yeah, sorry. Here's our other gentleman. So.
He's a gentleman.
Oh my God. Okay. All right, guys. Any more questions?
All right. I don't know. I don't know if you guys could see. I just shared. I obviously don't have the same amount of resources, but just for the corneal foreign body, I tried a few different methods of trying to make it from gelatin. It was difficult for me, so I just got these like pre-made, shell eyeballs,
Yeah.
and then I just, used clear school glue to glue metal filaments on there, and just stuck it in a styrofoam head. And I didn't have time to really super trial it, and or the residents tried it with the slit lamp, and it actually worked really well. Like they were able to pick the stuff off. It didn't come off too easily. I put a whole bunch of foreign bodies in there, so it's easy to get a lot of uses out of the same set of eyes. And then if it all comes off, you can just glue some more on. They still get the whole idea of being able to, use the slit lamp, use the 18 gauge needle, and then be able to pick it off the eye, it still looks like an eye, I guess.
The other benefit too with this is I use this for the trauma residents and stuff too when we were doing their sessions and stuff like that. And so with this, I also showed them some like fluorescein to it and see what does fluorescein look like when they're actually looking for it. And this will pool nicely with the fluorescein on it, and it won't like absorb in and things like that. So that also is helpful. And then one of our other physicians who was doing training with the PAs, and I wasn't there on that day, she used these eyes directly, and she put metal shavings over the top of it and heat gutted them for a second, and then they embedded in a little bit as well. So you can do that as well, whether you just wanted to go over. Interesting note about the ballistic gel as well is that if you stick two of these things together and you let them sit there, they will bond, okay? Even at room temperature over time. So when you want to store these, store them separately and sort of cover them. Moreover, if you cover them with saran wrap even, the saran wrap will start to make indentations into the surface of it. So when you store it, try to store them separate. If you can leave them uncovered or by themselves at room temperature, they'll be very stable. But anything you lay on them, anything you put on them, they will start to deform over time, even at room temperature, to get that form in there. That's why some of these are a little bit deformed right there, because I had them in a Ziploc bag, and that Ziploc bag sticks to it, okay? Hydrophobic, it will bond to itself. Just some interesting notes to say when you work on it, tricks of the trade when you try to mess with this stuff.
Any more questions, guys? Okay, so I'm going to see if I can proceed with my presentation. So this is going to be, I cannot follow that act. Okay, let's just put it that way. This is a very simple model, and you should have received the supplies for it. This is basically what you need. You can need a mannequin head, a styrofoam mannequin head, or pretty much any other kind. Let me just go ahead and turn my camera on. I was experimenting with the different camera model here. So what I wanted to show you guys, basically these masks go on sale after Halloween for $5 to $6 on Amazon. So I tend to like literally buy them by buckloads, and then I just store them and keep them. And all you need is a Halloween mask, scissors, white hair tie, just rubber band is fine, needle with a thread, mannequin head, and then again, after Halloween, you'll see these ping pong balls that will go on sale. So what you want to do is, this is what a regular mask looks like, right? And it doesn't have to be a human mask. It could be any kind of like monster or ghoul or whatever like that. So this is what that looks like. You invert it. You basically cut your hair tie pretty much in the middle. It isn't super complicated. And then you basically have like your two crura of your ligaments, inferior and superior crura. And then all you have to do is stitch it right there. So as I'm actually showing this to you, you can actually do the same thing. Basically go in there, just like that. And of course, I'm not gonna be able to stitch it, right? Because I'm on camera. That's usually how it goes. But all you're doing is going in, going out, making a couple of nice stitches in there, old-fashioned. And honestly, I'm not very good at stitching other than like surgical stitching, but it takes me maybe, I want to say 3 to 5 minutes per model to make. So it doesn't take a very long time. Okay, so all you're doing is just stitching into place like that. All right, that's it, you're done. And then you basically trim it out. So I like to do it at least 3 places, one on right over here and one on the top and bottom part, just like so. You take the ping pong ball, which is right over here. A lot of times you have to gauge whether the opening for the mask for the eye is going to actually fit in there. Sometimes it makes sense to just trim it a little bit so that it doesn't tear, because if it tears, it'll rip right through, okay? So it gives you, I've trialed this out with this particular size of a mask, and the opening for it seems to be working fairly well. So all you have to do is pop it in there, turn it around, and literally just push it out like that. Okay, that's literally it. You're essentially pushing it out. And so now your model is fairly ready to go. And the good thing about this model is that if you build it, you can actually have the same model and have 2 residents practice on each of the eyes, right? Because you have the superior and inferior crew. And so you can basically have 2 residents per eye. So that gives you 4 residents practicing this procedure per actual model. And then if you want to incorporate this model into your sim experience, you can actually have, you can launch this model on top of a sim mannequin if you really want to do it that way, or like the good old fashioned styrofoam heads work just as well. So this is kind of what it looks like, and that's literally all there is to it. So no, not very fancy, but it does the trick and it's cheap. So here I had used a Kennedy mask, which was on sale at the time for some reason. And then you can do it on the other side, and then you're ready to go. And here's how you're performing the procedure. So that's pretty much it. So this model is a lot more simpler than some of the other models out there. It isn't a huge amount of time. I'm sure there are better ways to figure out how to put the ligaments on there. And I think I'm probably going to end up improvising and sort of building on this a little bit more in the future. But, this is kind of what it looks like. I'm trying to get my mask on top of my model right here. And now it's ready to go. So somebody's holding it. You can go from here and from here and, do that procedure. So that's what it is. So any questions about this model so far? It's pretty simple, pretty straightforward, not very complicated. The next segment is going to be a little bit more scholarship and research focused, and it's a little bit more dense compared to the last few. So bear with us, and I think you're probably going to need some coffee as we go through this. So what we'd like to talk about now is the concept of what happens next. So you build a model, everybody loves it. What now, right? That's like the fundamental question. So what I'd like to propose at this point is the concept of research and scholarship and why this applies to model building. And why should we think of it? Why should we do it? And how do we do it? And this is very pertinent because a lot of times, and if you think about historically, when DIY models have been built, it's just become somebody's pet hobby. And then you kind of do it and it's awesome and great. But then in terms of when time comes for things like your writing your promotion packets and filling those out, right? Where do you put it? Where does it even factor in? Do you get quote unquote credit for it, especially if everybody loves it so much? So how do you make this into something that counts as research and scholarship and activity, academic activity? So I'd like to think about the concept of innovating and making models from the framework of Boyer's scholarship. And there are 4 aspects of Boyer's scholarship. So there's the discovery aspect, there's the integration aspect, the application, and the teaching aspect. And really what that boils down to is if you're going from advancing knowledge, in our case, creating a new model or a modification of an existing model, to synthesizing knowledge, to how you're applying that model in your teaching, and advancing and applying not just for your immediate residents, but also elsewhere. And then the teaching part of it, which is you're teaching about these models and you're disseminating the information. So you can think about it strategically, building models and innovating fills fulfills all these criteria. And taking it further to Glassix scholarship criteria, most of us, when we're designing any kind of procedural sessions where we're training, we come up with certain specific goals. We obviously prepare, there's adequate preparation. We use appropriate methods of pre-learning, post-learning, potentially even assessment tools. We look for results in terms of how facile are our learners with the models and the different procedures. And effective presentation, how are we presenting these models? How are we presenting the meaningful outcomes of these models? And then reflective critique, which is essentially an evaluation process. Majority of the time, this evaluation occurs somewhat not as rigorously. So it's very loose in the sense that you get verbal feedback about it. It's not like you're filling out a Likert survey or anything. But nonetheless, it is reflective critique. So if you take a look from a Glassix scholarship perspective, if you are able to provide a detailed model description, for example, one with step-by-step instructions as well as videos, you submit activity evaluations for it, which show the relevance of the model, and several other constructs. I will get to that in a later slide. You include an assessment tool with clear goals and objectives for your activity, and you include your pre-learning resources, and then you disseminate, you are in fact applying scholarship. So your innovation has now become a scholarship, and you can document this and put this on your CV and put this on your promotion packets to say, look, this is a deliverable that I have delivered. And through iterative process of building and rebuilding and publishing and republishing, you're really setting the trajectory for future models. So in terms of research and scholarship, we mentioned some of these things before. Here are some of the journals where we have had success in submitting descriptions of models, along with some of the things we mentioned before, such as clear goals and objectives, clear pre-learning, clear assessment. Journal of Education and Technology in Emergency Medicine is a good one. Curious, you can also submit to the ALEM blog and the Western Journal of EM, are all examples of places where you can submit descriptive models. So we don't necessarily have to take a 10-minute break right now because we just did, but now that you published a model, the next step is, what do you do next, right? So one of the things that is very big in terms of your ability to support your model, in the sense that you're going to get asked this question very frequently, is how do you know your model is valid? What is the validity behind it? So I wanted to throw this out there to the group out there. What does validity mean? And what does validation mean to you? So can you use the chat function to sort of scroll down and sort of jot down some of your thoughts about what validation means to you? And have you ever been asked this question with respect to the model that you have built? This would be a great time to interact. Okay, so assuming that most of you have had some time to review the pre-learning article that I sent, I'm going to use that as an example.
A couple comments here, reproducibility, ease, and does it teach critical actions for that procedure?
Sure. So I think those are all things that go into it. So reproducibility, ease goes to a certain aspect of it, and whether it teaches critical actions definitely goes to certain kinds of validity. But what validity is, the sort of generic definition of validity from Cook and Beckman, which is the article I had sent out, is the extent to which an instrument, right, that's the literal term used, accurately measures what it intends to measure. Okay, an instrument, that's the definition. And the vast majority of the time, if you look at educational and simulation literature, they refer to validity of an instrument as in a checklist or a global rating scale, a simulation assessment equipment or a tool. So there are different kinds of validity that you can get, right? And I like to think of validity as a hypothesis. Okay, so it is a hypothesis, and you want to collect evidence in favor of this hypothesis, or potentially beware of evidence that might refute the hypothesis. So looking at this, I guess, hexagon, there's different kinds of validity. So there is face validity, which is the old-fashioned way of looking at it, where you look at something and you kind of decide just by the look of it, does it look appropriate? Then there is content, which basically is a way to look to see if whatever instrument you're using, does it fit the construct that it's supposed to portray? The consequences, are there any unintended consequences of you using the assessment? Relationship to variables, which is basically, a couple of different things go under that category, but the evidence really suggests things like, is your instrument able to discriminate between senior and junior learners? Or how does your instrument compare with respect to another measure, which is either discordant or concordant? In the response process, how do the learners, as well as the faculty who's observing, how do they respond to the instrument? And then the internal structure, which is really the vast majority of the time reported as things like reliability. How reproducible is it? How reproducible are the results that are measurable? In the new paradigm, when talking about checklists and global rating scales and assessment tools, face validity has become somewhat of an obscure and little used aspect. But construct validity, which is basically all the rest depicted here by the arrow, is what the modern definition of validity is with respect to instruments. Now, one caveat though is face validity is still quite well used and extensively used in engineering literature. And as we're going to discuss later on, I think there is a considerable overlap between some of the models that we're building in engineering, to be honest. And so we borrow from that. So face validity still features quite heavily in model building in engineering. And so I think that there is a role for it here. So having said this, I'd like to engage you guys in a group activity, which is a validity challenge. What we're going to do here is that I'm going to give you an example of a kind of validity, and I want you guys to tell me which kind of validity it is. And please use your chat functions to use it, and please engage, because I think this is a fun way to understand the concepts. Any questions so far before I start the challenge? Okay, all right. So you're going to have about 20 seconds. So the first example, you have a statement. The statement is the UAssembly Step 2 CK seems to test basic medical knowledge. Therefore, everyone passing it should be ready to take care of patients. What kind of validity would this be? And there's no wrong answers. Please engage. So choose one of the A through F to see which one you think this is. Anybody? Any guesses? Okay, so it's actually face validity. Okay, and basically what that is looking at it, does an instrument or a model appear to portray the concept it's trying to portray? And so a lot of the, more contemporary scholars consider this similar to looking at a car and judging its speed by looking at its color. So it's a red car, so it must be fast, right? It doesn't make sense. And to an extent, this is true for a checklist or some kind of assessment tool. But when it comes to a model, if you have a model that totally does not look anything like what it's trying to portray, that is a considerable thing that you have to address, right? So there is a role for face validity when it comes to model building. Okay, here's another example. You have detailed explanations of questions and detailed explanations of the answers and this rationale on a test and with very specific links to the EM milestones. What would this be an example of? What kind of validity would this be an example of? Wow. Okay. Yep, Zach is correct. It is in fact B. So content validity, in fact, because it goes into detail describing the construct and why the construct exists. And so this would be an example of content validity for sure. The relationship between test content and the construct of interest. So consider the example of the cracothyrotomy model. Why does that model depict, you know, a cracothyrotomy? Like exactly why. So detailed description of exactly why, and so on and so forth. So example 3, while practicing a cracothyrotomy, learners are asked to voice out each step of the procedure or think out loud, and why, and while at the same time, the trained observers for this procedure are filling out a checklist of the actions. So what kind of validity would this describe? This is one of those nebulous kinds, and I always had a hard time understanding exactly how to report this validity until I realized that it was really simple. This is actually response process. Okay, this is the fit between the construct and the detailed nature of performance actually engaged in. From the viewpoint of the learner who's actually performing a procedure or performing an action, and the observer who is either a faculty member or a simulationist who's actually, you know, looking at you perform and giving you feedback on it. And the idea is you literally voice out how you're going to perform the procedure. So from the perspective of the learner, you voice out every single step of the procedure. And from the perspective of the observer, you give them feedback, but also if there's any kind of like, you know, rate or training that you've engaged in to try to make sure that your observers are on the same page, that constitutes the response process. And how do you describe this when you're writing up a model or the validity for it? You literally describe what you did. You had your learners voice out the different steps performing a procedure, or your trainers, you actually had like a 30-minute session or 20-minute session to make sure that everybody was on the same page when they were filling out a checklist. Like that's the response process and you're describing it. Okay, example 4. 2 independent observers score the same checklist and look for concordance in scoring. What would that represent? I know the first couple of times that I did any kind of reading on validity, my mind was spinning. So I understand this is a very, very deep topic, and I don't expect everybody to, you know, sort of completely get it. But it is quite important because the things that you look for are quite simple. Any guesses? Okay, so this actually is an example of internal structure. So internal structure is essentially data internal to your assessment tool. Most commonly, it's reliability. Other times, it's factor analysis. So, you know, reliability being the more common one is essentially reported in terms of Cronbach's alpha, which is essentially if it's more than 0.7, it's pretty good. And so that is something that if you have a checklist or some kind of global rating scale, it'd be nice to report something like that in terms of robustness for your validity. Here's another example. A student practices intubation on a task trainer and then is noted to have increased first pass intubation success in their anesthesia rotation. So if you are in fact able to document something like this, any takers? Okay, let's see here. Yeah, so definitely. So there's a little bit of overlap. So these are consequences, so unintentional consequences or intentional consequences, but there's also actually what we call generalizability, which is basically relationship to variables that falls under the same umbrella. So the generalizability part of it is that it actually is applicable because they're having increased, you know, first pass success, but it's also generalizable because practicing with a mannequin is now having a direct effect in clinical care. So it is generalizable. And so if you can document that, you know, that is a really, really good source of validity. So relationship to other variables is a very broad term, and there's a couple of different things that fall under there. We just talked about generalizability, to what extent is a model or assessment applicable to the real world? Okay, so this one is interesting. So you have an EM attending who performs better on a cricothyrotomy assessment checklist compared to an intern. What would that be? So yeah, that's the relationship to variables. You're exactly right. So this is the other part. So this is discriminant testing. Okay, so that's what this is. And this is kind of like a little bit more sophisticated with respect to validity evidence, which you might have to do a little bit extra in terms of your model if you're thinking about it, or your checklist if you're thinking about it, the divergent conversion testing. Okay, so practicing the steps of placing a central line under ultrasound guidance on a simulated model decreases the incidence of pneumothorax post-training. What would this be? So again, this is one of those things that is like the holy grail, right? Like you really want to get an outcome like this reported if you can track it back to your central line trainer, for example. This is an example of consequence, right? Because this is a positive consequence and it's an intended or unintended consequence of your test use. But other things in the consequences that you can report are very simple things like, cost analysis of the models or the checklist that you're developing, for example. What kind of impact did it have on your learners? Or do they feel more confident going out and performing a procedure? Things like that. So with that, I'm going to come back and discuss some of these things in the tying back together, but I want to hand off to Dr. Stapleton to talk about the procedural checklist, because the validity, as we talked about, a lot of the evidence is focused on assessment tools.
All right, thank you so much. So yes, I will briefly talk about procedural checklist creation. Next slide. So I know, excuse me, early on, this can seem a little bit overwhelming. It seems like a basic idea, and then you start breaking things down and you're like, oh my God, forget it, never mind. We're gonna break this down into a couple key steps that you can kind of refer to get you on your way and to use to troubleshoot. Next step. So concept is the first one. It's really looking at the very basic why question. Next slide. Drafting will be the next one. And as is a common theme throughout this and really almost anything, it's going to be an iterative process where you end up brainstorming with a lot of people. Next slide. And then piloting also, shockingly, will be iterative process where you want to improve this in real-time usage. Next slide. So breaking into concept a little bit more, this is really the why do you need this, right? Were you voluntold that you have to suddenly do credentialing in the hospital and you need a reasonable mechanism to do this? Well, that's pretty high stakes. Is this for publication because you have this cool model and you want to show that it does something? Is this for your own almost model validation, going back and forth, making sure you really thought about the key steps and that the model you designed actually reflects those and vice versa? If you learn nothing else from this, repeat after me. Does it already exist? Does it already exist? We love to make up checklists and all this stuff. I don't know why. We're all, I guess, inner MacGyvers and we like to create, etc. But like, how many airway checklists have you seen? How many central line checklists have you seen? Like a gajillion. And that's fine if they all fit slightly different needs. But if they're all filling the same need, then why don't we just iteratively improve on each other's and go from there? So that's one thing. Does it exist? If it does it actually fit as is? Like WHO and other people are coming up with more and more, and that's great. If it doesn't quite fit, can you use it as a base and sort of adapt it and retest it? Because you know what? Having designed half a checklist is way better than having to design the whole thing. And then if it doesn't exist, then that's fine. And at least you've done your due diligence and you're not going to feel like an idiot when you go to publish it and someone's like, well, why didn't you use this validated checklist? And you're like, oh, because I didn't know it was there. Oops, my bad. Sorry. All right, and then lastly, you always want to think about what format, right? So format as far as it can be paper-based, it can be online. This is kind of to avoid, I can't tell you how many times I've had to like duplicate work doing this, so it kind of helps you get it in that format from the get-go. But also, do you want yes, no answers? Do you want approximate scales? What kind of data are you looking for? And with that, really, are you looking to break this down into a checklist where things were done, or a global rating scale where things are looking at the global view? These all have implications as far as what stats you use if you're going that direction, and then who is going to be using to rate these. Next slide. So here's an example of this like beautiful checklist from the WHO, right? This is like graphic design material if you saw the whole thing. Mine will never look like that. That's okay. So you can see on the left side is actually the item that you're checking in the subgroup, right? It's very easy flow, airway, breathing, etc. On the right, present and functioning rather. That's it. That's all. Next slide. This is a global rating scale from otolaryngology paper on EM Crike, actually. And this isn't the tool that they use, but these are the questions, just so you guys see. So you can see the rating scales from 0 to 4. And in general, it goes from like failed to perform to done successfully or very well, or et cetera, some modifier. And really they're breaking down these things a little bit more, right? This is the key, like essential step. Did they actually position the head? Do you want to do the crike like this, where you can't have any space? No, probably not. You want to like get the nice view. Do you want to actually, I'm going to skip down and say, was there stepwise progression, namely flow, which is like an interesting way of wording that, but that's a different ball of wax. So was it all over the place? Was it like they had to keep switching instrument hands and move side of the patient and, you know, like go back and reposition and do all this stuff? Or was it like cut to, you know? I think we all sort of seen the difference between those. Next slide. All right, I want to call this the pyramid of Stapleton because everyone has a pyramid, but it's really more of a circle that I made into a pyramid, but that's fine. So drafting, this is of course a cyclical process, as is everything. The 3 elements that you're going to be doing in whatever order you need to do are really identifying essential steps, getting a panel of experts, and thinking about the design of your instrument. I'm telling you a little bit more the publication way of doing things, but at a minimum, when you are coming up with a checklist or a global rating scale, whatever it is, show it to at least a few other people who understand the key part of the concept of what you're doing and what you're trying to measure, because everything makes sense to us, right? And then you go back 3 months later and you're like, I don't even know what I meant by this sentence. I thought it was great at the time, but what the heck? So get that feedback you can. So even if you just show it with a few different people in the department, that's bare minimum, and that's super, super helpful because it will help you mitigate any ongoing miscommunication issues. Ideally, you and maybe your panel of experts, you may form a Delphi or a modified Delphi if that so suits. You're going to identify the key essential steps, or maybe something's been published with those steps and you just need to adapt it into a checklist or a global rating scale or group it differently. And kind of go to your experts, talk about what you think those are, and then you can start writing it out. So is it just going to be in a Word document? Maybe you write it down and it's there, and then you go back and show another friend, like professional friend, and they're like, what do you mean by question G? And you're talking about crikes, you're not even talking about tube securement. So then you're like, oh my God, I didn't even think about that. I was just like tube in the hole. So then you go back to your essential steps and think about what is the beginning of this and what is the actual. Okay, you're going to kind of go through this a few times until you feel like you've got it as best as you can. Next slide. Oh, great. So this might be something you're if you're looking to do a little more of like a Delphi or modified Delphi process, where you identify these steps and you're getting people's feedback on whether or not they think it's essential or not essential, right? So step 1, everyone agrees is essential. Step 2, 75%. Step 3, 50. Step 4, 75. So you can see everyone agrees on step 1, great. But the other steps you're going to need to talk about, or if you've already determined there's a certain level that you're going to get rid of, or you're going to rework them, et cetera. But you have some data to work with on that. Next slide. All right, piloting. This is, to me, always the really interesting thing because it never works the way you think it's going to work. You end up learning quite a bit. So this is really to use it with a small subgroup of people to get as much real feedback as you can on it. So 2 who's. 1, who will actually do the rating or the checklist or whatever it is, the assessment, and who will be the learner. So at a minimum, you want a couple of people, again, who are able to use this to rate a couple learners so you can actually see and ask them a couple different ways to do it. You can follow in real time and ask them what are the issues, how do they interpret the questions and answers, or you can just have them go through it in real time, do a comparison, and actually then follow up with any issues. So additionally, getting to some of that validity that Noreen was talking about. So you want, ideally, again, you want to be able to look at or assess different learners on that scale, right? You'd like to see some novices and you'd like to see some experts, because if there isn't really any discriminant function, then what does that really tell you about your tool? You're probably looking at the wrong thing or looking at the wrong population, et cetera. So you really need to see that span of things. That will also help you see how different people interpret different things. All right, moving on to reliability. There's different ways to do this, but in general, the basic gist is that you want to make sure the questions and answers read similarly to a number of different people. The formal way to do that is through stats with something called Cronbach's alpha. Generally speaking, you don't have to memorize it. I'm not going to go into it, but there are ways to do it. And that's inter-rater reliability. And then lastly, what if it doesn't work? Pretty sure it's not going to totally work the first time, and that's okay. Generally, they'll be like 75 or whatever % works, and that's awesome. You don't have to worry about it. That works. You're done. You're good. Maybe there's another like 5 questions that you need to look at, and there was confusion about how it was worded. There's confusion about the answers. They felt like it needed to be broken down into stuff. Or maybe the whole thing is just junk, and you're like, well, I'm glad I did that because that's useless, and then you kind of go back to the drawing board. It's kind of rare that that happens, but it does happen. Next slide. All right, so this might be another example of piloting. Let's say you have 3 experts and they grade 2 students each, right? You can look, you can see right away just gestalt is that student 1 didn't do step 2, student 2 looks like almost everyone agrees they did almost all the steps. So you might even propose that student 1 is probably the novice learner, they skipped a step, and student 2 is probably the more. Next step. All right, we're gonna look at a couple examples. So I tried really hard to find examples of terrible checklists, but unsurprisingly, no one wants to publish them, so I made a really bad one. So go with me. At first glance, like I actually love this. I'm like, it's super easy. There's tons of white or black space or whatever you want to call it. There's only 3 questions done. I can do this, no problem. So my first question was, a patient intubated? Yes, no. Okay, like what, in the sim session ever? Like without fail, what like ever? Okay, great, sure. That's super not clear. Was the patient connected to the vent? Again, ever, vent settings, anything else matter? This sort of gets almost to like SMART goals, et cetera, how you're really picking it. And then lastly, I love this one. Did the doctor at any time pause during the intubation? You're like, okay, English aside, that's kind of a confusing sentence, but like pause because they sneeze, pause because they need different equipment, pause because the patient was waking up, was a hypermetabolizer and they need more meds. Like, what does that even mean? All the data you're going to get from this is like unusable, to be honest. And I love even my scale. I don't even tell you how to mark it, right? You just mark it wherever, like there's no real information there. All right, next slide. All right, another example of a lovely checklist. This is one from Rubinster et al. It's like this beautiful 2-page checklist with some information on the side, very well designed. But what I like here is that it's very simple. Yes, no, yes, no, yes, no. So this is post-intubation care. Did you secure the tube? I'm going to say, did you place the OG or NG? Did you get the radiograph? Did you start the meds, et cetera, et cetera? And I have to admit, just for clinical interest, the very bottom one is verify that airway equipment is ready for the next patient. Oh my God, that's awesome. Love it. Ready to go. Next slide. So this is from a paper on ED thoracotomy looking at the global rating scales a little bit more. So they broke things down into steps. They have this Likert or Likert scale, apparently some people say. And you can see how it takes a little bit of knowledge about the topic to actually be able to judge that reasonably. So on the lower end of the numbers is unsure about location, depth, length, et cetera, that hesitancy that surgeons especially are like, not good. And up on 5 is adequate location, depth, exposure. So you can see like the novice learner, we've all seen it, right? You make a little cut on the left lateral and it's got to be expanded both directions. It's not deep enough, it's jagged, et cetera. Versus the like trauma surgeon comes in and is like, no, cut, done. Same thing with pericardotomy. On the left there, screen left, I guess. Did they identify the pericardium, the phrenic nerve, et cetera? Or God forbid, did they cut through it? That's no good. On the more expert end, they clearly identified it. They were able to actually hold it, right? Pericardium is kind of slippery, and they were actually able to cut in the proper location. Okay, I think last slide coming up. All right, this is the overarching global rating scale, and I have to admit I have a fondness for these. So this is meaning your gestalt over same thing, the ED thoracotomy paper, your gestalt about the whole procedure, soup to nuts. How did they perform? Novice 1, expert 5. Competent in the middle, that's a different story. I know, loaded word there. But the nice thing about this and what I found with a number of papers is if your gestalt, people are very generally good about reading gestalt. That should kind of grossly align with where people are falling on the more itemized questions. And if it's not, you're probably missing something or asking something inappropriate. And but you can use this as a way to explore when you're doing your piloting. What do you think the difference came from? That's it. That's all. Thank you very much.
Guys, so I'm going to jump on into this learner activity, and I actually need your help as a part of like coming to some kind of consensus about how to do this. So the question is, how would you go about obtaining validity evidence for DIY models? You've heard a whole bunch of stuff about making models and publishing models. Now, you know, we learned about validity evidence in the context of building and developing checklists and assessment tools, and there's some overlap there. But just wanted to have a little bit of a discussion, and you can, you know, use a chat box to please throw out some thoughts there. How would you go about obtaining validity evidence for any one of the models discussed right now, or something that you may have built? Anything? Anybody? Any takers? I know it's getting towards the end of the afternoon where everybody would rather be, you know, getting on to happy hour and socials and whatnot, because I know there's some virtual socials happening right now. But any kind of input would be fantastic. Okay, well, we want to think about the validity hypothesis and introduce a slight change to the definition, which is the extent to which a model accurately portrays what it intends to portray. And this is where there is the overlap between DIY models and assessment tool. And what we want to propose is, if you look at your task trainer that you have built, you basically go from there. Excuse me. Hi, honey. Oh, wonderful. You want to go do this? Yeah. Okay, here you go. No worries. Have a good time. We just woke up from a nap. Anyway, where was I? Okay, so task trainers. So what we want to talk about is things like, you know, you build a really great task trainer, and how can you use what you're already doing to extract these streams of evidence that we talked about in the shape of the face construct validities, as well as, you know, how do you make it more formal so when you write it up it looks, you know, all nice and pretty. There are three different aspects here. So you have the task trainer build, you're talking about the validity testing, you're talking about rapid prototyping and beta testing that we introduced before in the assessment tool. And the following slides are just a suggestion for how I think this can be done. So when we're talking about face and content validity, when you're actually doing your rapid prototyping, record everything, even if it means you have to like go around with a little tape recorder or like your phone to record people's opinions. Do that, because when you have that, you actually have objective evidence for what is working and what is not working. And when you're documenting that process, that is a part of your face and content validity. Okay, so who would be the primary person who would be giving you their advice? Other simulationists, your sim techs, you know, things that you're going to ask them about are improvements, you know, whether the model that you build, could it be used for assessment? Right in the beginning of this presentation, Dr. Michela had put up a slide about, you know, what is the reason for you to build this model anyway? Is it for, you know, deliberate practice and mastery learning? Is it for assessment, or is it a combination for both? If your model is meant for assessment, you know, this is a very good time to start getting opinions of the people who are the stakeholders, such as your residency program directors, such as the residents themselves. Like, would you use this model for assessment? Now, with respect to your simulationist, also things like ease of construction. How quickly were you able to build this? What about time and cost efficiency? So if you document these things, also procedural and tissue fidelity, when you start documenting this, if you record it, you can do a, you know, thematic analysis or some kind of a narrative analysis on it. But the idea is that when you're documenting it, that is your validity evidence right there. Now, with respect to face content and some aspects of consequence and generalizability evidence, you can use your beta testing and evaluations. So you've gone all the way to build these models. The next step would be to actually have some kind of a evaluation for the activity to circulate to your learners and also to your instructors and observers. So with this process, you can again get at procedural fidelity, tissue fidelity, confidence in performing procedure, right? That's a big one because that gives you generalizability to a large extent. And hold the thought about confidence in performing the procedure in real time, and then coming back 6 months afterwards and repeating that question and seeing if they've made if it had any difference or made any impact. And then with respect to, the things like deliberate practice and mastery learning, again, the learner and the instructor can give you feedback on that. Is this something that you can do over and over and over again? Are you getting those steps in the way? And again, application and applicability to real world. Now, internal structure and response process are also things that you can document within the context of how you're organizing your activity. So this doesn't really take anything extra other than having a model, having an assessment tool or some kind of checklist that you are filling out when people are performing a procedure, and then having an evaluation, okay? But with respect to the response process, remember I told you it's very, very subjective. It's kind of this sort of weird nuance where you're literally asking your learners to think out each step of the procedure that they're performing. And if they're performing each of the procedure on the model, you can document that or record that and see, does this make sense? Performing the different steps of a crike, going through, palpating the appropriate landmarks, making the incision, et cetera, et cetera. And then with respect to the instructor and the observer, if there's any discussion that you've had with your observer about how to appropriately fill out your checklist, that technically counts as rater training. It doesn't have to be a very 90-minute affair. It can be 20 to 30 minutes where everybody's on the same page about how they're going to fill out the checklist or global rating scale, okay? And then the actual sheets, when they're filled up, or if it's electronically filled out assessment tool, use and see if you can get some of that data for reliability testing to see if there's any concordance amongst your raters. If you have 2 or more raters, you can check to see if your convex alpha for inter-rater reliability for that checklist or assessment tool is more than 0.7. And even if it's under 0.7, if 0.6 is pretty moderate, I mean, that's pretty good in terms of reporting out. And then the consequences, like I mentioned, these are some of those things that are, most people don't really go on this and don't really report this because it's difficult to get, but how do you get it? You essentially send up a post-activity follow-up survey 3 to 6 months after. It is retrospective, it is self-reported, but you can glean, was the procedure lab that you did on this topic useful? Did you get to implement anything you learned in real life, right? Those are valid data points. And the impact on patients, if there is any improvement in clinical performance or reduction of procedural complications or adverse events, I mean, that is something you definitely want to report. The relationship to other variables is taking it to the next level. So, I mean, all the other things that I've said so far are fairly simple to reproduce, but relationship to other variables requires a little bit more planning. And there's 3 different ways to do it. So you can do a model comparison, which is essentially take your model and compare it to the gold standard, which could be the patient, it could be the cadaver, it could be a commercial model. And you can, have your learners compare the models to each other and basically get objective data like time to performance of procedure and scores in an assessment tool. You can also get generalizability data, like I mentioned before, from your evaluation survey, but also your post-training follow-up in 3 to 6 months. And then discriminant testing, which is again something I'm hoping to get some help from you all, is the concept of novice versus expert testing. In other fields besides emergency medicine, if they have developed any kind of procedural models, the way they put it through validity testing is to actually get discriminant testing between novice and experts for the procedure. So for example, they're going to have interns perform a procedure and they're going to have an attending physician perform the procedure. And they're going to rank it or assess them both with respect to time to perform procedure and scoring on an assessment instrument. But this is where it's sometimes challenging for us because a lot of the procedures that we are performing, high acuity, low occurrence procedures, we're not technically experts in that, right? Because they're so rare. So that's where the challenge lies. And that's where I need your help. So, from Dr. Casera, who basically showed me 3 different models for expertise and what mastery means, I think that ED attendings kind of lie where I have shown you right around here in red. So they may not be, for things like a perimortem C-section, they may not be unconsciously competent, right? Because you just don't get to that level, you don't perform that many. And they may be somewhere between proficient and expert on the Dreyfus model. And of course, they have to do it when time comes. So the idea is, how do we define expertise? Specifically for these models, some of which we presented today. And there is a poll here, which if I can figure out how to do, Andrea, can you potentially help me, because it disappeared off my screen again, unfortunately, the poll. Yeah, so here's a poll. So here's each of these, procedures. And what I want you to do is I want you to think about it for a second and let me know, who do you think should be the expert? Is it the ED attending who should be an expert in this? Or do you think it is a specialty physician like an OB-GYN or a perimortem C-section or a trauma surgeon for thoracotomy? Because how we define who these experts are will also affect how we're going to go about building our evidence and our validity with respect to how we gather those kinds of evidence. So please take a couple of minutes and fill this out. Does anybody? Because I can't see. I can't fill it out, so I don't know how to do it.
That was really interesting.
Yeah.
You're
So,
not necessarily what I would have predicted. Yeah.
Yeah. So like, for example, I do think that's really interesting for some of you guys who filled it out. So hopefully some more of you will, because I think, it's very telling that some people would consider the EM physician as an expert for C-section, a perimortem C-section, but it seems the majority here seem to be more inclined towards specialists like OB-GYNs. For ED thoracotomy, it's like 100% should be EM physicians, whereas for crike, some people still think that it should be a specialty physician. I mean, maybe head and neck surgery or and surgery. There's agreement about corneal foreign bodies. There is, again, like 2 people think that EM physicians should be the experts at draining priapisms, but one person says no. So yeah, so I think the peritonsillar abscess, again, three people think that it's physicians and one person thinks it should be a specialty physician. So
we just say this is really interesting. So we're experts in ED thoracotomy and abscess drainage.
Well, yeah, I mean, that is really important to know, right? Because again, how often do we do these? So I think that just kind of looking at it, just looking at the gestalt, like for perimortem C-sections, you want specialty physicians, OB-GYNs who are going to be experts, right? Why does this matter? Like, I hopefully get more people to respond, is because based on this, we can go back and say, okay, this is the consensus from the people who kind of reviewed this. And this is how we want to go about building our evidence. So if we're going to get like a specialist to give us feedback about the model, it would be, the OB-GYN. But yeah, so thank you for participating in this. And if it's okay, we're going to use some of these results to report back going forward. Anybody else want to weigh in? Anybody? I'm not going to push it. And it's getting late. Okay, thanks for that. All right, so I'm going to share the results, so hopefully we can get some of these results. All right, so let's move on. Okay, come on, now I can figure out how to move on. All right, so one of the things that we are wanting to do at the Sim Academy is this Sim Academy MOVAP project, which is basically the Sim Academy Model Validity Project. And what we want to do is propose a systematic approach to validity evidence for existing models. And believe it or not, we're the reason why we want to do this is because it's not just the existing models that we have built that sometimes lack validity. In fact, a lot of the commercial models, if you look at it, the only thing that's reported on them is beta testing. They don't necessarily report validity, and don't really report validity evidence per se. So I think that there is something here that we can utilize in a more systematic way to propose a couple of the models and how we can beta test it amongst different institutions and simulationists and learners, and then really report their, face content and face and construct validity, and potentially even identify avenues for discriminant testing. So to that end, if anybody present here would like to get involved with these projects, please reach out to us, because you may have a project of your own, but you also have seen some of the projects that we have displayed here that we are very interested in trying to get some validity evidence going for, and then also writing and developing some nomenclature around what it means to validate a model as opposed to checklists and assessment tools. So in conclusion, finally here, building models definitely counts as innovation. It definitely counts as scholarship because it fulfills a lot of Boyer's and Glassex's criteria. And then if you do it in a systematic way, consider gathering validity evidence for your models so that you can start reporting it. And then definitely disseminate it so that people can review what you've built it themselves, improve it, and then disseminate again. And so for any questions or any interest in any of the models and or any of the projects mentioned just far, please reach out to me. And that pretty much is it. So I'm happy to take questions. I know that it's been a long day and most of you guys are itching to get out, which is fine. So we ended a little bit early, but if you have any questions, please, please, please reach out now or use the chat function. I'm also going to include my email here in the chat box so that you guys can contact me there if you like. Any questions, any comments? I know the last hour was super dense and not as exciting as the first half. Yeah, all our email addresses, most of our email addresses are listed here in the chat, so please feel free to reach out. But with that, no questions? Man, you guys are awesome. You guys have totally got this. So I'm looking forward to hearing from you in the future. And then, yeah, I'll give you the rest of your afternoons back. That's it.
Thank you so much.